My name is Scott Fisher, and I'm the chair of the Minnesota Board of Psychology. Welcome, and thanks to everybody for being here. So I will introduce our subject very briefly because I have no special expertise in cultural humility and just here learning with the rest of you. But cultural humility is defined as a lifelong commitment to self-evaluation and self-critique, with the underlying knowledge that we're not finished, that we never arrive at the point where we're done learning. So as opposed to a content, learning a body of knowledge about a culture, it is more of a stance toward understanding other cultures and people from other cultures. So it's considered to be a process rather than content-oriented approach. Another aspect of cultural humility is that there is an aim and an understanding that there would be a hope to correct power imbalances that should not exist. So our first speaker today is Georgy Krupin from the Center for International Health. And he was born and raised in Russia in the city of Saratov on the Volga River. Graduated with a master's degree in clinical psychology from Moscow State University. That's Moscow, Russia, not Moscow, Idaho, correct?
Right.
That would be an interesting coincidence if it was Idaho. Received a PhD in marriage and family therapy from the University of Minnesota, Department of Family and Social Science. In 1994, he started seeing patients at the Center for International Health as a volunteer, and then later as a provider. Besides doing individual and family therapy, he has taught family therapy-related classes at St. Mary's University, done conference and community presentations on cross-cultural mental health and collaborative healthcare. In 2000, Dr. Krupin co-authored a chapter on New American Families in a handbook of family development and intervention, and in 2007 co-authored 2 chapters on refugee mental health in Immigrant Medicine Handbook. In 2011 and 2012, he served as an interim co-director at the Center for International Health, and currently is the lead mental health provider at the Center for International Health. At this point, I will turn it over to Dr. Krupin.
Thank you.
Yours. You are welcome.
Good morning. It's an honor and a privilege to speak to your own people. And it's the most difficult thing because on one hand, you feel like you're preaching to a choir. And on the other hand, people are most knowledgeable. And the things I will cover today, most of you probably do every day anyway. And so I'm I would prefer a different format where it would be a dialogue, a conversation, but then it is what it is, so we'll proceed with the lecture, and I hope we'll have some time in the end with questions and answers. I'll say a couple of words of what exactly I'm going to cover today. Once, several years ago, I saw my primary care provider at Como Clinic, and she knew I was a provider at Health Partners, and she asks, well, what do you do there? I'm saying, well, I work at the Center for International Health, and I see refugees and immigrants. Not only, but for the most part. And she goes, oh, you've got a very sick population there. Well, and on one hand, it's true. On the other hand, I think together with suffering and trauma, I see a lot of strength. If I didn't see strength, resilience, and coping, I wouldn't be able to do it for 23 years. I mean, I would get burned out completely. And I think that's the focus of my presentation today, to try to make sense of it. Because I think if we don't make sense of what we do, if we don't find strength in patients and they don't become our partners, it's a doomed enterprise. It doesn't work, and everybody knows that. So I will talk more about how I try to make sense of it every day, not so much about techniques and numbers, although some numbers I will take. The way I see it is that, for the most part, we dealing with people just like you and I, just like us. It's just that they are under very different circumstances. If anybody in this room, if we would be just literally displaced right now, somewhere in a different country where we would have nothing, no language, no relatives, no money, no connections, everybody, every single person in this room would have some mental health symptoms, some more, some less. And some of us probably had experience of that happening to them already. I'll talk about several things. First of all, the general picture of what's going on with refugees, and I will try to see it from the eyes of people who experience it, rather than being a mental health provider trying to evaluate. We'll talk about some barriers that people face when they try to access healthcare system and try to adjust in our country, and how in the process we have challenges and how we can find strength and resilience so that we can find their agency, their desire and ability to invest in their own health, and how we can build effective partnerships with people. And I'll talk about some specific things that I do every day in the clinic. Hopefully it will be helpful and interesting, and we can discuss that. Let's start with some statistics. Current quote for refugees is about 70,000 people a year, and has been stable and has been filled, although God knows what's going to happen now with the changes in policy and current administration. Refugees as of 2014, majority came from Somalia to Minnesota, then people from Burma through Nepal, as is Nepali refugees. Oh, I'm sorry, Korean through Thailand. Some Nepali from Bhutan through Nepal, and Ethiopian and Iraqi refugees. Currently, or at the last census, we have about 7% of foreign-born citizens in Minnesota, and obviously everybody's concerned. We all try to help them struggle with different challenges in the process. But actually, when we look back in 1920, 1 out of 5 Minnesotans were foreign-born. Can you think of that? And there were no social services, no arms workers or case managers, and people struggled and survived. And that's another testament to their strength. 2 major languages spoken in Minnesota besides English are Spanish and Hmong. And major groups are Mexicans or Latin Americans, and people from India, Laos, Somalia, Ethiopia, Vietnam, and Thailand. In sociological and psychological literature, we usually discriminate between pull immigration and push immigration. Pull immigration, people coming for better life. Push immigration, people running for life. And that's who we mostly deal with. People who are refugees because they can't go back to their country. Here's the definition of a refugee: is a person who, due to the well-founded fear of being persecuted for reasons of race, religion, nationality, or other, is fearful to seek protection in his own or her own country, and reluctant to or unable to return to their own country. Of course, people who come here, they get a lot of opportunities, and first and most important is safety. People are running from death or destruction or damage to their homes and families, but also freedom of communication or information. Many people get opportunity to engage in cultural development because their culture was denied back home, such as Oromo from Ethiopia, for example, or Nepalis from Bhutan, and a lot of other people. Freedom of faith, again, maybe this is now being questioned, unfortunately. And of course, for some people who have all sorts of disabilities, it's a chance to improve their quality of life, to be more independent and self-sufficient. However, together with opportunities and gains, people lose a lot of things. And first thing, of course, obviously, is language. How many people in this room were in the country where they didn't know the language and were lost and confused? Quite a few. And then you have a little glimpse of what it feels like to be completely, out of control and not to know what to do. And I guess most of it is you being short-term, but imagine going and living like that for life. This is every day. Not knowing language reduces us to like a 3 or 4-year-old who can only gesture and try, to look for people to be nice to them. And people aren't always nice. Loss of independence and self-sufficiency. I think this is a big one. I think we often underestimate how confused and lost people feel when they come here. I do some immigration waivers, the AN 648 form for citizenship, waiver for citizenship exam. Believe it or not, I have people coming from Lincoln, Nebraska for me to do evaluation on the citizenship exam. So a person who is doing 8-hour shift in the meat processing plant finds somebody to drive her over here for 8 hours for one hour session, then they drive back and she goes back to work, and then she has to come for her second appointment for that. Now, between Lincoln, Nebraska, as you know, and Minnesota, or St. Paul specifically, there are probably thousands of providers who could do immigration waiver. Any licensed psychologist, any medical doctor, any licensed independent clinical social worker can do this waiver. The person who does that only relies on the word of mouth. She knew somebody who lived in St. Paul who said, there's a guy in St. Paul who can help you with this paper. If you imagine how much in the dark she is, that she does, everything else between Lincoln and St. Paul is complete darkness as far as help. This is hard to overestimate, and people live their lives like that every day. I had a Hmong patient who's been here for over 10 years, and at some point he's on welfare, he's 50-ish, and at some point his insurance lapsed, and he didn't have he thought he didn't have dental insurance either. He had severe toothache. He pulled 5 teeth by himself with pliers, because I don't mean to scare you, it's just to show that, and as you know, the insurance is retroactive 3 months. So basically, he had access to insurance. It's just that after 10 years in this country, he's so out of sort of a control and out of touch with what's going on that he resorts to, measures like that. And then finally, through our social worker, he came to the clinic and fixed the insurance and everything. Again, I think we underestimate how much people are in the dark and how much they're troubled by their experience here. Security and stability. We think that life is stable here, and in many ways it is for us who are well off and who have jobs and who know language and who are sort of but not people we're dealing with. They are a lot of them completely depend on welfare benefits, on insurance benefits that can change any day. They can lapse, they can lose their sort of a coverage. Their housing, they're covered for 3 months, and then after 3 months they're supposed to find a job, and if they don't, which many don't, they risk to lose their housing, etc. It's always, maybe they had a small home or small residence back in their country, but it was theirs for life. Nothing is going to be taken away from them unless some people with guns come and take it away. Here, life is very unpredictable and unstable for people who are not well off and have steady jobs. Loss of material possessions. We think that, people come to land of milk and honey, but a lot of our people, the refugees we work with, they were very well off back in their countries, even if they're good farmers. They had their farm, they had their house, and all the other stuff that they owned for life. Nobody, again, would take it away from them. They come here, they're nobody. Even their apartment, it doesn't belong to them. It can be taken away for a variety of reasons any moment. Loss of value of education. Well, we have a Russian-speaking doctor who was a practicing cardiologist back in Russia for 14 years before he got here. It took him 11 years to go through externship, internship, and to get licensed and to start practicing. And he started practicing when he was already over 50. Very few people do that. Very few people do that. And for some countries, I think, it's extremely important, like Iraq is coming now. Iraq is very educated, on the average, are very educated, and most of them very professional and skilled people. They can't. Most of them can't confirm or, refine their licenses, get the education, get through. So, they end up either being, non-skilled workers at some random place, cutting meat or stocking things, or they can't find the job altogether. Roots and connections to cultural traditions. Well, short story about my first experience with Halloween. I had no idea when I got here what Halloween was all about. And we, my then wife and my son, we lived in a student housing complex with tons of kids. So come Halloween, like 300 kids would roam around the place and just knock on your door and everything. So I was told that I should buy some candy. I bought a pound. And then I find myself giving away Coca-Cola cans, and then when a group of teenagers finally came, I was giving away carrots. After that, we closed the door, went upstairs in the bedroom, put off the lights, and hid there waiting for them to just go away. It was a scary experience, honestly. Well, this is a joke, but it happens every day. It happens from how you say hello to people. What's the distance? How do you get invited to visit people? Lots of things like that. Family and friends, I don't probably need to explain that. Especially in other cultures, family is even more important than here. We'll talk about it a little bit more. If you lose it, you lose half and more of your life and your identity. Your friends, as they say, are keepers of better parts of yourself. You go back to your friends to reclaim your good self. And if they're not there, it gets much more difficult. Loss of status. We did a study in Wat Tam Kaboka, last Hmong refugee camp in Thailand, back, I think it was 2003 or something like that, before the last group of Hmong refugees from Thailand came to the United States. And a lot of older men on the refugee camp, they refused to go. They heard from people who were already there that back even in the refugee camp, they were people of high status, both in family and in the community. They were respected, and they had duties where they would perform, rituals or engaged in some cultural practices and stuff. When you come here, you become just old sick guy, and nobody needs you. And that's true. So they were refusing to come, and some of them threatened suicide. Most of them, under pressure of their families, ended up coming here. But this is a true challenge. People lose status, especially men who come from more patriarchal societies. They lose a lot of status. And you don't recover from that. This is a loss you don't regain. Self-esteem. One of my patients was a kind of depressed old man drinking. But I find out that he was a commander of a nuclear submarine. Can you imagine a life of a retired commander of a nuclear submarine in this country? And this guy was just an old drinking guy sitting in a public housing apartment. So eventually he ended up going back to Ukraine, where he came from, because he couldn't stand it. It was impossible. We talk about individual challenges and individual problems, but I think the biggest and the most important thing that is overlooked is changes in the family. And we're not doing enough. I'm not doing enough about that. Families, a lot of families are destroyed in the process of immigration. First of all, the foundations on which families are built are different from this country and most countries we're working with. In many countries, people have arranged marriages, and the whole family, the huge extended family, is part of it. There's no nuclear family. There's a huge group of people basically organizing it and holding it together. When you move over, this whole thing falls apart. And there are the forces that bind marriage, they're non-existent. For many people, they may not have been this affection and love and whatever, between one person and the other. So it falls apart. You can see, everybody who works with refugees sees that. Very hard to fix, if possible at all. Of course, changes, as I just mentioned about Hmong refugees, in power structure, huge. Men in patriarchal societies or older people, just by definition, by being older, they get respect. Men, because they were sort of perceived as providers and head of the family, they received respect. Everything changes here. A lot of the time, women pick up language faster. They're more flexible and adjust better. I'm not even talking about kids. I'll talk about kids later. But power differential shifts, and it's not working anymore. Lifestyle changes. I mean, in countries like Iraq, former Soviet Union, et cetera, both, and anywhere, come think of it, both spouses worked. They didn't spend 24 hours, sitting home looking at each other. It wasn't the plan, And if this happens, it's a huge challenge for a marriage. It's kind of a totally different foundation and totally different lifestyle. And of course, with age comes sickness and other problems, financial problems, more and more challenge to marriage, which eventually suffers. Parents and kids, another huge area. I think, at some point, it'd be nice to have a conference or something about what happens to parents and kids, because it's probably number one reason for suffering in, let's say, Somalia among mothers, problems with their teenage kids. Power differential, kids learn English faster, they adjust faster, they have support system, or at least some reference system in schools and such, and parents don't. And parents oftentimes ask their kids to interpret, they ask their kids to help with paperwork, they ask their kids to drive. And then how can you parent a kid where he is stronger than you? He has more power in social sense. It's all upside down, and this is a disaster. And kids, although they may seek this freedom, they don't know what to do with it. They're not prepared, on a level of maturity to deal with this thing. Not even talking about values, traditional values. It's a whole different sort of a problem, both because parents and kids may have different values, but kids actually struggle with conflicts of their own. They split apart. Part of them is raised and belongs to their parents, and another part is, trying to acculturate. And this value clash inside of them often projects outside, and then instead of resolving the conflict inside, they fight their parents. And all results in parenting crisis. We also, a lot of the time, talk about parental abuse or corporal punishment. Nothing compares to parental helplessness. This is the worst. When parents are helpless, and which they are most of the time with teenage kids, they're very good at taking care of younger kids. Feeding, dressing, But when it comes to social things and adolescence, they're helpless. And this is a complete disaster, which leads to a lot of conflict, a lot of estrangement and distancing between generations. To summarize this whole thing, I think looking at that, we can see that refugees experience huge changes in their lives. They lose a lot. And I think for me, it was very important to understand that I can't pretend we're going to fix it. Like there's a tendency in our field to say, okay, now you're here, you're safe, we're going to fix it. We're not. People lose parts of their lives like they lose limbs forever. And it's a tragedy. Somebody said that the last real tragedy was ancient tragedy. Because after that, when Christianity came, there's always redemption, there's always hope, there's always salvation or some silver lining. Greek tragedy, nothing. You're done. You lost it. No silver lining. No coming back. No redemption. Look at Medea. Look at, talking about Medea, by the way. There was a case with a Hmong woman about a long time ago, about 20 years probably back, where her husband found a second wife and left her. And she got so desperate and enraged, she killed her kids. And of course, she was, evaluated severe depression, post-traumatic stress disorder, abuse victim, da, da, da. And then I go to the theater of Junlun, if you remember there was a theater like that. And I see Medea. And this is exactly the same story, if you know it. Jason, who brought his wife from, when he went to, Kolchida for Golden Fleece, he brought a wife who was a local Tsar's daughter. And then they had 2 sons, and then he found a younger woman. So she slaughtered their 2 sons and brought them to Jason and said, look what you've done. You brought me here. I left everything for you. And then you left me for another woman. You destroyed everything. I have no life. So here. This is not mental illness, although it's extreme. This is sort of the drama of human existence. And it's been there. People don't change, at least not in 2,000 years. And of course, we see it and treat it differently these days. But this is what we're dealing with. I don't want to, make it sound dramatic, but it is. That's what we're dealing with. And I'm trying to make sense of it and understand how we can help people get through this, although we can't, make it go away or forget about it. So we have people with their experience coming here in the end. First thing that happens, they have to deal with us as a system. They have to deal with healthcare. They have to deal with school systems, social services, welfare, this and that, and the other thing. And a lot of the time, it becomes a problem. Because, not only because this is a foreign system, but because by nature of things, a person or a family and a system are 2 different things. They function on different laws. We study family therapy, and we know that the system is bigger than the sum of its parts. It has its own laws of functioning, and sometimes these laws are inhumane. So and there's a lot of misunderstanding. We're trying to help, but because there's no feed, strange things happen. First of all, sometimes we can see a pattern where the more help we offer, the more help is needed. And if you work in the field, a lot of the time it's very confusing. I have a patient who has infectious disease case manager, mental health case manager, arms worker, ILS worker, and she is applying for the PCA. And her daughter, who's 15 years old, she has a mental health case manager. And she also has a child protection person because there was a problem in the family. Can you imagine all these people working with 2 people, with just mother and daughter? I'm confused. I don't know who. I mean, roughly, I know what's the difference, but there's a lot of overlap. There's a lot of confusion. And I went as far as going to St. Cloud, because the patient is in St. Cloud now, to meet with all these people, try to put it all together, because it wasn't working. And it happens all the time. So then the more, instead of making, I think ideally it should be one person doing all those things. Like imagine having 5 parents. One would be responsible for general strategy, and then the other would be just hands-on tactics, and the third one will teach you specific skills to do things. And this is crazy, but that's what's happening. And we're trying hard, and it's not working just because the system and the unit are functioning on different sort of levels. Sometimes it develops into lack of trust and problems. People see something's not working, and so they think it's just because they are not being treated fairly. And it sort of brings back all the old memories. Like, for example, for Russians, I would say for anybody who comes from former Soviet Union, you don't trust the system. This is how you're raised. We all were raised in a sort of schizophrenic world where you're very loyal with your people, but you don't trust the system. So you sort of congregate in the kitchen and talk about how awful things are. By the way, this is the difference when you, cultural thing. You come here, you ask somebody, how are you? They say, I'm fine. If you say fine for a Russian person, that means that you go away, I don't want to talk to you. You're supposed to share some of the stuff that you use. Life sucks, this and that. But that's okay. That'll be a normal answer. Because we function on a different level, we define problems in a totally different way. I was invited once to one of the local hospitals to consult dealing with a family of a very sick lady. She was a woman in her 80s who was suffering from terminal cancer, and she was stage 4, and she was almost unconscious by the time dying. Everybody knew she was dying, but the family was very aggressive. 2 sons, very aggressive, demanded, treatment and as much as possible as to 100%. And the doctor thought they were just extortionists. They threatened to sue the hospital. Chaplain got involved, this and that. So they were looking for Russian specialists. They thought it was a Russian thing. So they got me, and I came in, and we sat, family, the patient was not there, she was in bed. 2 sons, patient representative, doctor, nurses, da-da-da. Doctor comes with a dictaphone and says, well, does everybody understand that this patient is going to die and there's nothing we can do about it? Everybody goes, well, yeah, can't deny it. He says, okay, good. And I said, no, that's bad. And brothers both go to me, thank you. It was just instinctive reaction as an outsider. But this was the moment that changed the whole thing. And then we started talking, and we realized that the perspective on this is totally different. People understand that she's going to die. And they say, why do you want, meds and care? Because we don't want her to suffer too much. We want her to die in peace and less suffering. The big thing was taking her vitals instead of once a day, twice a day. Why do you want that? Well, because we need to know when she's passing. We all want to be there. And this is a vital information for us. Can you do that? Well, of course, this is not a big deal. And the case was resolved. But that was, and everybody was caring. The doctor was caring for the patient. But there was complete mismatch in perspective of what exactly is going on and what people want from there. The problem of the referring person, sometimes people get over-involved. And I'll talk about one other case real quick. When the professional is over-involved, it changes the whole system. It may change the boundaries of the system. So we had a Hmong lady who was hard-hearing, and because she was born hard-hearing and nobody took care of it, she was developmentally delayed. And she was a second wife for an older man, Hmong man, who was a shaman and who had a first wife and, 6, I think, kids with the first wife. So because they couldn't kind of transfer the whole family here, they had to split. So the first wife went off to live on her own, and he now lived with his second wife, which is this lady, and 6 kids. Now this lady, because of her handicap, she was completely unprepared to take care of the family and the kids, because the first wife was doing that all the time. And when they moved here, the stress increased, and people started going crazy. And the husband was abusive to her. He wasn't abusive physically. He knew he couldn't do it. But he was abusive verbally, emotionally, and the hard-hearing advocate who was involved with the family took action. At some point, she removed the lady from the family and put her in the women's shelter. Then the whole hell broke loose altogether. Can you imagine, developmental delay, she didn't hear anything. She didn't speak any language at all, even Hmong. She knew just like little homemade sign language, not official sign language. And she ends up in an American women's shelter. What's going to happen to her? And then the family left on their own altogether, trying to work it out. So 3 months down the road, the hard and hearing advocate changes the job. She disappears from the picture. If you introduce yourself to the family, if you become a vital member, you have to stick with it or do something about it. So of course, in the end, and this lady who's in the shelter, that's all she knows, her family and nothing else. So she ended up going back to the family. But before it happened, there was so much stress and so much turmoil, just because we have a totally different perspective on things. So when this happens, we make family systems and individuals even more helpless, even more needy, and it reproduces their trauma experience they had before. It's just a couple of words on relationship between adjustment disorder and post-traumatic stress disorder. I think post-traumatic stress disorder is a very important issue, but I think it's way, way overemphasized over the stuff that we've just been talking about, the adjustment issues. It's just the experience of helplessness that brings back the symptoms of post-traumatic stress disorder. But the problem is here. But the problem, and I think one reason why we always go back and, okay, let's work with the trauma, because it's easier to sit down in the office and talk about trauma instead of giving her housing, hooking her up with services, finding a school for kids, this and that, and that. It takes more work. So we end up just sitting and chatting instead of having more social workers and having more people who would be involved in doing these things. So what do people do when this happens? And there are basically, as I see, 2 different strategies. Some people, being frustrated with all the services and everything, they shut down, they sit home, they don't go anywhere. And they just close themselves off. Other people start frantically pushing all the buttons they can reach. And people who are in the case management or social work can relate to that. I have to say, Russian-speaking immigrants are very good at that. They know all the buttons. Because they used to deal with the system like that back home. So they're trying to reach and pull all the buttons and all the ropes they can possibly do. They get annoying, but they get the results. They manage to move through the system. And I would prefer that rather than people shutting down and giving up. Unfortunately, or this is what it is, we end up in this triangle where people come to our office and bring all this stress to our office, whether they explicitly say it or not. And we need to see this picture and understand, at least make it clear, what's our part in this? What is our job and our responsibility? That will make it easier. Let's talk about other barriers. One of the things I wanted to talk about is this notion of stigma as it comes to mental health. We all say that, we all know that people who have mental health problems are stigmatized. But I think the the issue is much more complicated. We all see pictures like that in the media, okay? How refugees, oh, I'm sorry, they may be refugees or just mentally ill people are treated in their own countries, in Sudan, in Somalia, Kenya. This is a woman from Sudan who is severely mentally ill. This is a guy from Pakistan. But when you look at statistics, you realize they don't have qualified help available. Available psychiatric services is like 1/200 of what we here have in the United States. So people have to do something. This kid is a Somali kid in a refugee camp who is obviously severely mentally ill, and he is just tied with a rope by his ankle. Well, let me tell you this. When I was 3 years old, I lived with my grandmother. My parents went to a different city to do their degrees. And when my grandmother was going shopping, and it would take her a couple of hours to stand in line, get food and stuff like that, I would be home alone. So what she did exactly this. She tied me with a rope to a dinner table. So I couldn't sit by the door and wait for her, or sometimes crying, because it was cold, and I was getting cold if I sat there. So please don't get me wrong, I'm not equating my situation. I had the most loving grandmother, love her dearly, she did me. But what can you do? Kids or problems or people with problems are managed in the way possible. If you look at cultures we're working with, it's a very complex attitude. So I heard a Somali social worker speak and said the phrase that I remember, mild to moderate mental health problems are absorbed by the family. That's how it works. It's only the extreme, the people who are, as they say, walk around naked and talk to themselves, that's who is stigmatized. Because they're dangerous and something needs to be done about it. Not for any other reason, not for moral or ethical reason, because of practical reason. And so what do? Treatment approach is totally different. Many of you probably read this. Rwandan, talking about Western mental health practitioners. Their practice didn't involve being outside in the sun where you begin to feel better. There was no music or drumming to get your blood flowing. There was no sense that everybody has taken a day off so that the entire community could come together to try to lift you up and bring back your joy. Instead, they would take people one at a time into these dingy little rooms and have them sit around for an hour or so to talk about bad things that happened to them. We had to make them leave. It's true. And if you look at studies of World Health Organization, they did studies in India and other countries following people with chronic persistent mental health problems. How do they do over time? How well do they do over time? They found that people with CPMI in those countries who live in the communities over time do better than the same people in the United States because they're part of the community. So it's not stigma. It's not that they're ignorant. It's not that there's something wrong with it. It's that we don't have what they need to make them feel better. It says more about us than about them. And come think of it, maybe we don't have what we need to make us feel better. And we're trying to do this with mindfulness and, self-help books, but it's the lifestyle. We're running. We don't say hi to each other. So it's the difference between the two worlds. They see it differently. On to other problems, normalizing. Just quick, each topic I think could be expanded and talked about, but it's too much. Normalizing, I think normalizing is a huge tool for people to survive. It's totally amazing how much people can endure and what they get used to. I've been facilitating Vietnamese re-education camp survivors group for 17 years now. And you listen to those stories and you look at people, what they've been through. Horrible stuff. And now there are people like you and I walking, talking, you wouldn't tell something's wrong with them back then, 30 years ago. But at the same time, normalizing can be a huge obstacle to treatment or to seeking help. People get used so much, they think that's normal, that can't be changed. And you probably see it all the time. And, well, that's from God, and only God can change that. Well, yeah, but we can help, right? And so a lot of the time, normalizing and showing strength is a barrier to coming and seeking help. Lack of understanding of mental health services. Of course, people don't know what therapy is, what psychology or whatever. And that's why I think a lot of education needed. But also, I have to modify my approach. I can't do cognitive. In the very first session, I have to create an experience where people feel some difference. Through breathing exercises, through mindful, anything I can do. So a person who comes, I don't need to explain to them what psychologist is. I show them what's happening when they come and what can I do for them. And then we do more and more and moving on and on and on. Yeah, of course I talk, but the most important part for me at the intake session is to show something. And not just to show, make it happen. This should be an experience. It's not, again, explaining how you should breathe. I drill people to the point where they say, yeah, I feel the difference. There you go. That's what you need to do. And you'd be surprised, maybe not surprised, how many people do simple breathing exercises and find it extremely useful. When you drill it to the end, when you make it happen in the session, right away. Another huge, our fear of we don't know what to do. We're afraid to ask. Most people here don't. But people who are, even physicians, are very, very sort of on the edge about that. Shall I ask? Shall I do this or shall I not? I work with probably, 30 different cultures from different countries. There's no way I can know everything or even most significant cultural things about all those cultures. Impossible. I think the key to cultural competence is humility, is be okay with our incompetence. Know that you don't know about these people. That makes you free. That makes you free to ask questions, challenge stereotypes, both yours and theirs, and then you have conversation going, and then people feel more free and open to work with you. They know you're different. One special thing is overuse of medical model. As DSM clearly based on medical model. Most of you probably know the Rosenhan experiment, where they had people fake psychosis, and they sent them to 12 different hospitals, and they were all admitted, and they wouldn't let them go. Even they started behaving normal and saying, oh, no, there's nothing wrong with us. A lot of people were forced to take medication, and some of them stayed in the hospital for months. And they were faking it. Well, hospitals, Rosenhan was a professor, psychology professor at Stanford. So he did this study in the 70s. So some hospitals got upset and they challenged Rosenhan. So send us people, we'll figure it out. So he agreed to the second part of experiment. And in the second part of experiment, those hospitals who challenged him were able to pinpoint and identify some patients who were fake patients. It turns out that he didn't send anybody to those hospitals. Doesn't it make us humble, in how we evaluate people and how we assign diagnosis? I think very important to remember that all of you know how DSM evolved, right? It started from a model where there was explanation to mental health symptoms. Symptoms were signs of distress in DSM-1. It was based on psychoanalytical model. And there was some logic. It was some kind of a connection, how things develop. But then, as it evolved to DSM-3, 3R, and on, it became strictly medical. So symptoms were looked at as symptoms of disease. There's no, you know that DSM is purposefully not etiological. It doesn't make any connection with life or whatever. PTSD is one of the, if not only, single disorder that is connected to a specific stressor. So it's signs of disease. Although DSM is very useful in communicating, it's our language, we need it for insurance purposes, we need to have some sort of a common frame of reference, I think it's totally insufficient when we think about our patients and specifically about refugees. We can look at culture as sets of behaviors and beliefs that people develop in their efforts to adjust to specific life circumstances. This is useful. Whatever people do makes sense. This is another kind of a slogan that I repeat over and over. Everything makes sense. Even pathology can make some sense. There's some positive or rational element in that. If we accept the medical model, then the symptoms are abnormal. This is maladaptive behaviors, and they're based on biology, changes in brain chemistry. Nobody denies brain chemistry, but it's much more than that. If you accept medical model, then you need to cure the patient and bring him back to a sort of a pre-existing state. If you accept just existential humanistic people's perspective, then all human reactions in some ways, in some place, in some context are adaptive. They make sense. People are trying to survive and doing something to make it happen. And mental health symptoms sometimes just signs of efforts to do that. No treatment can return people to the previous condition. It happened. They lived through depression. Even this experience of living through depression changes them forever. This is not the same person, and you can throw it out of the window. It's useful. Not only they lived through it, they overcame it. They showed strength. They found some resources to deal with it. It's very useful for the future. If we throw it out of the window, we throw the most valuable aspect of treatment in the future. But then, it challenges us. If we accept that people changed forever, if things are sort of different and ambiguous, we have to deal with this ambiguity. We have to accept that people need to balance loss and hope. And it's much, much more difficult than just showing, the bad stuff out of the way and being so positive. It's yes and, always. It's the balance of things. And I think it's, at least for me, it is as challenging as it can be for the patient to accept that and start working with that. Let's look at the most common mental health problems I see in my clinical practice from sort of again, humanistic perspective, from existential point of view. First of all, most mental health problems can be seen as developing, fighting the so-called catastrophic condition. Kurt Goldstein was a German psychiatrist who then ran from Hitler and ended up in the United States. And so he defined catastrophic condition where an organism cannot cope with the demands of an environment and it feels threat to its existence or to values essential to its existence. Every human being has threshold of stress beyond which the situation becomes catastrophic. Catastrophic condition involves the impossibility of ordered reactions. The relationship between self and the world breaks down. So in response to that, organisms or people do something. One of the reactions is to shrink their world to a manageable sort of a space where they still have some control, or they at least perceive it as a controlled state. If we look at anxiety, the way people feel it, that something's not right, I have to do something, and I don't know what to do. But the constant thinking, the constant worry is actually can be seen as an attempt to control things. I'm doing something. I'm not just letting it go. I'm trying. This is a sort of at least subjective attempt to control things. Depression, I've tried everything. I failed, and I give up. It's exactly you're trying, you're failing, you're sort of failing, and then you decide, okay, I'm going to shrink. I'm going to shrink my world. I'm not going to try. I'm not going to hope. I'm not going to desire. The two biggest things, like take PHQ, so-called PHQ-2, the sadness and lack of interest in doing things. We stop being interested in doing things. We shrink our world, and it feels safer. It feels sad. It feels, void, but it's safer. PTSD, something's going to happen. I can't do anything. And the most essential factor in any trauma and post-traumatic stress disorder, this is my fault. This is negative self-attribution. It does a lot of damage to us, but if you think of it, guilt and feeling this is my fault is an attempt to regain control. If you think of it, if this is my fault and I didn't do it before, that means I can control it in the future if I behave differently, which is not true a lot of the time. Which is this is exactly the challenge, to live with this, partial lack of control, the balance. I can control this, but I can't control that. And if that is my family, if this is my children, it's hard to accept that there are situations in life where I can do nothing. But we strive not to accept it, and then we feel guilty thinking, okay, next time I'm going to do something about it. Why am I doing this? Because I think if all you see in those symptoms is pathology, then you don't see strength. If all you see is just their deficit, then you don't have agency, you don't have partnership, you don't have people to work with. And this is the only way we can make a difference, to develop their agency, use their strength to build our partnership. And let's talk about that. Agency, the notion of agency and notion of communion are used in health psychology and medical family therapy, where agency is the ability to get invested in their own health, and communion is our capacity to help the patient, to make them feel welcome, to make them feel that this is their place, they're in the right place. It's somewhat similar to Carl Whitaker's notions of battle for structure and battle for initiative, where battle for structure is us showing that they can trust us, that we know what we're doing. We're strong enough to contain their troubles. Battle for initiative comes next when we shift initiative to them, and they have to work to make things happen. The law of therapy, as you all know, if patient doesn't work more than you do, nothing happens. They have to be invested, motivated, and working at some point, maybe not from the start, where we have to get to that point, where they work more than we do. Then we have change. Otherwise, we get burnout and dependence and this and that and the other thing. The good thing is that people's strength and agency is always there. That's why I was trying to redefine mental health problems and other issues from a positive kind of a standpoint, that I do believe people always do 100% what they can at the moment. I really do believe that. And their agency is always there. We need to find it. It may be misplaced, it may be not effective, but it's there. Talking about fighting for yourself and fighting for agency, I went back and found Martin Buber, who was an Austrian-born Israeli Jewish philosopher who talked about the fight of being versus non-being. He said, all over life, everything that we do is this fight for being. Another philosopher, Paul Tillich, kind of elaborated the concept and pushed it a little forward, identifying 3 dimensions where we fight against non-being. Physical, where we're basically fighting against death. It's everything. It's our ability to move, our ability to have space, our ability to stay healthy, strong, do things, move. Everything physical, from space to physical energy, is basically a fight between life and death. If you get old and you can't move as you were able to move when you were younger, you die a little bit. We all die a little bit every day. And at the same time, we fight with it. We fight through other things, through fighting other physical sort of facilities, or in other dimensions, in spiritual or moral. Spiritual is fight for meaning against emptiness. And it happens with our refugees every single day. And moral is looking back and being able to say, I did the right thing. I suffered, I did this, I did that, but I did the right thing. And it makes a whole difference. The trouble is that sometimes these dimensions contradict each other, or there are contradictions within dimensions, of which I will talk a little bit more. First, could you name a behavior that helps to accomplish all those things, that help us structure time as we fight for our being? Helps to focus, inner locus and control over emotions, physiological, helps with social things, and sense of control. Employment. Anything else?
Connection to the community.
Right. Other? My option is smoking. Look at this. Smoking does all of that. That's why people smoke. And that's why they drink. And that's why they do, gamble, do all other things. It comes with a high cost, but it does all those things. It's wonderful. People are not stupid. If it was just plain bad, nobody would do it. Right? It helps you to structure time. It helps you to calm down. Come think of it, it's the same breathing exercise, in and out, in and out. You focus in the, it's a very mindful technique, just with side effects. That's the problem. So that's why I think it's very important to look at different problems as we see it, as coping strategies. They may come with consequences. They come with side effects. They sometimes may not be so effective, but they work on some level. They work on some level, and we need to find it. For me, it's always, the improvisational comedy. Who was it? Tina Fey, she wrote a book, and in the book she says, it's always yes and. You can't say no. Then you stop. Well, sometimes we have to say no when people are in danger, acute danger. But most of the time, it's yes and. Yes and. Because there's energy in what they do. There's some benefit. There's some sort of a push, and we have to use it. Because then they own it, and then it's their business, and we can help. We talked about depression in the same sense, and there was a book by Roger Solomon, the Noonday Demon of Depression, and he defines depression as a reduced vitality. That's exactly it. People shrink their existence to a manageable state, so it doesn't hurt anymore. Because trying hurts, hoping hurts if it doesn't happen. I worked with Jewish Family Services, and they had a project, they probably still do, working with Russian-speaking immigrants with depression, older seniors. And very difficult. There were issues with assessment, this and that. They've been trying and trying and trying. But come think of it, it's another example where depression has adaptive value. If 80-year-old sick lady who is single, isolated, if she would be full of energy, what would she do with it? She would go crazy. It would be worse. I mean, it's kind of people shrink down to whatever they can do. So it makes sense. Just a quick on anxiety and post-traumatic stress disorder. Somali patient or anybody else, you know what's happening in Somalia right now, in Ethiopia, getting worse. It's not the post-traumatic stress disorder. Their stress has never ended. It is continuing. They're living it every day because families, friends, everybody is back home. So it's not what happened in the past. Stress and trauma is now. Van der Kolk is very useful. He talks a lot about that. Trauma is now, here, sitting in front of you, in the body, in the mind. It's not somewhere in the past. So when people have crisis in, say, physical dimension, you get conflicting things. Okay, I know I need to quit smoking. I don't smoke, but I know I need to quit smoking. But then it makes me more anxious. I don't know what to do. I don't know how to keep myself busy. And simple things like I hear from Russian-speaking, I know I should be on a diet and I shouldn't eat like a bacon or salami or this and that. But this is my last joy. There's nothing else for me to be happy about. So yeah, I can do a little and a little and a little. And how it goes. People, for example, PT, we do exercise. You understand that the notion, the concept of exercise is in Western culture. People that you will go and make yourself tired and it will be good for you. This is crazy. In normal, in developing countries, people try not to be tired. Not to be tired is good. So it's a completely sort of reverse. Then simple things like physical, going on medication. Yeah, it helps you, but it has side effects. And it makes you dependent. People who come from third world countries, they cannot be. You have to do a lot of work to persuade them that this medication will be available to you for life. Nothing was available for life in their life. And they're right. We're in some ways, we're in denial. Things may change tomorrow with insurance coverage, with jobs, with this and that. It's just in this country, most things are very stable, and so we project it to. They're in some ways more realistic about things, and their refusal to be dependent, they don't want to give away their control of themselves, control of their lives, because that's how they survived. That helped them survive. Spiritual dimension, we can go on and on. People lose any kind of meaning. The most difficult thing I hear when I ask people, what are you hoping for? Nothing, I'm waiting to die. What do you do about that? The only thing I could come up with is to say, in this country, they won't let you die so easy. So they will keep you alive for another 30 years. And if you don't do anything about it, it'll be miserable. So you better do something about it. Moral dimension. You hear it, you probably hear it all the time. No, I can't take it. I can't think of myself. My son is back in Africa. I can't. I don't deserve. As a mother, I have no right to think of myself before I took care of my children. Or I didn't take care. I lost my relatives, blah, blah, blah. So I have no right. I have no right to be. That's a hard one. So as all those dimensions, go against each other, it's very difficult to untangle it and to understand what's going on. And if we don't, we see their behavior as resistance, non-compliance, et cetera, and label it in medical terms. If we see it in negative terms, then Their behavior is not purposeful, and we see it as patients' weakness. And then we fight against their agency. If we define it in positive terms, then we understand that people are always fighting. The proof is that they're sitting in front of us. They have been doing something to survive to this day, and we need to find what they did and help them do that and learn other things to survive. The agency is always there, and that's how we make them our partners. Now, we build partnerships. How do we do that? Everybody knows that 85% of effectiveness in therapy is attributed to non-specific factors. That was a huge mega study that analyzed different approaches in therapy and effectiveness and everything, which means that patient-provider relationship is the key. And it's based on trust, it's based on our caring attitude, it's based on access, safety, and the time we take to build our working relationship. Again, back to basics, sort of an existential perspective. Martin Buber has a book called I, Thou, which is about what kind of relationship we have with the world and with other people. And he says there are two types of relationship. I, it, when we treat another person or a group of people as an object, and we use them to achieve our goals, and it's up-down relationship, or I-thou relationship, when we are, at least in some points, we can be equal, and we can listen to each other and be open to new experiences. I think this is the key component. This is not all of it. We're experts, and we need to assert our expertise. But if we don't have this element in our relationship, nothing's going to happen. We won't have a partner. We will end up pulling this whole thing on our own. And of course, you all know that because you do it every day. It's just I think that it's very, in the age where everything is focused on technique, statistics, skills, it's very important to emphasize and re-emphasize. This is the key relationship that keeps it alive. By the way, you probably know that Rogers built his theory very intensely using Martin Buber, and they actually met, and there's a book of dialogue between Carl Rogers and Martin Buber where they kind of discuss similar things. One of the key components to this is power control dynamics in patient-provider relationship. I did my dissertation with Dr. Jim Maddock, University of Minnesota, on power and control issues in families, where power is defined as ability to influence, and control is negating or stopping it. It's basically fire and ice, energy and freezing kind of thing. And every relationship, every person has it, and we're talking about balance in these two that defines the relationship. And initially, we are in a power position. And if we don't shift to a balance, if we don't help the patient find power in them, then we get a lot of controlling behaviors from the patient. And controlling behaviors, it's not just, fight, flight. It's a flight in different versions. Flight, pretend to be dead, or pretend to be crazy. Flight is a no-show. People stop coming. If they don't feel something's going on, we don't see them anymore. Dead is when patient kind of mentally absent. Oh, I don't remember. Did we do this? Oh, I forgot. So whatever you do, they're almost not there. And crazy when people do random things. They take random medications, they do things, they don't do things, they show up, they don't show up, so everything. All those, I think, are signs of patients not having enough say, not making their own thing. We need to get to a point where we have balance in power for them to be able to assert their goals, state and assert their goals, to change things, to challenge us, to say no to us. And I start doing it from the very first session, from the very first meeting, when I start asking patients about their past and things like that. And I say, I know the things we talk about are difficult, but my job is to ask questions, so I will be doing that. Your job is to make sure you're safe. I don't know you yet. I don't know how to keep you safe, and I may not know. So say no. When you feel it's too much and we feel it's inappropriate, say no to me. I'll stop and I'll listen. Trauma is loss of control over yourself, starting from your physical body. We can't talk about it. We need to do things right here and right now to help patients regain control. Give them control over what you talk about, over how often they come, over what they want to talk about. They may not be in a position to say no. A lot of people are not ready for that culturally and otherwise. But it's practice. We introduce it and we work on it. We introduce and work on it. That's the only way. Now, when we do this, we challenge ourselves. If we kind of create a balance of power, that means our loss of power. And that's scary. We had a case in our clinic with our psychiatrist who used to work with us, Dr. Field. We had a Somali patient who had paranoid schizophrenia, who was acutely suicidal. He was looking for ropes, at home. And the family brought him in, and the situation was so urgent that his brother flew in from the West Coast just to stay with him. He left his business in Seattle, came to Minnesota and said, I'll stay with him. And our initial intent was, of course, hospitalize him as soon as possible. But then you think of it, okay, non-English speaking Somali patient with paranoid schizophrenia, you hospitalize him for 2 weeks. What's going to happen? You keep him safe for 2 weeks. Now he goes back home and everything happens again. And the family was strongly pushing us not to put him in the hospital. We'll take care of him. We'll watch him 24/7. We'll make everything safe. So we were going back and forth a long time. And then eventually, given his history, the rapport with the family and everything, we decided to take a risk and leave him in the family. And it was okay. But it was scary. But we thought that we empowered the family, not him maybe, but the family. And they were empowered in their capacity. They went into their natural way of coping with things. Because eventually it will still be up to them. We can't always be there, and if we find a way for them to function on their own, this is the way. But that's scary. And we have this challenge all the time. Giving people or living with people having more power means that we need to accept our limitations. So what do we do? What have I been doing? One thing, 15 minutes or so. One thing, I think I have a patient, Cambodian lady, whose life was, from my point of view, was horrible. Since she was a kid, she went through child labor camps. She was in Khmer Rouge, then older camps. Then she was in a refugee camp in Thailand. And then she came here with her mother. And her mother was frail and elderly. She was basically, sorry to say that, but for the last 10 years of her life, she was basically a vegetable. But she refused to put her in the nursing home. She lived with her. She had no sleep because her mother's schedule was random, any time, day or night. She had no kids, no personal life, never married. Very intelligent, very strong, very good woman. And it's very depressing to see her and listen to her. But she always used to say, God sees me. God sees me. And she was very firm. It wasn't just words. She really felt like that. Not to equate ourselves with gods, But I think this is our main job, to be a witness. To be a witness. And to understand that sometimes there's not much we can do, but people need a witness. People need somebody to be there, to listen and be a witness how hard they fight and how hard they struggle. So it doesn't go just unseen. As I mentioned, the first thing I would do in the session to try to give people control back and say that my job is asking questions, your job is telling me what you want or stop me when you can't take it. I think, again, it's all about experience here and now. It's not talk, talk, talk. Again, something I mentioned before, asking stupid questions, don't assume you're an expert. It's freeing both for you and the patient. If you assume too much, I think I'm much worse therapist with Russian-speaking patients because I assume too much despite all my efforts and everything. When people say, you know what I mean? Oh, yes, of course I know it. Nothing. I know nothing about this person's history. By the way, I think the important thing is that everything I say can be applied to any patient, not immigrants and refugees. It's just that when you talk about immigrants and refugees, I'm so grateful to have this experience because it's extreme. It's like under magnifying glass. It's so much in your face, the difference, you can't deny it. And that teaches you, okay, you don't know. You don't know. You need to be open. And I think this is the biggest cultural competence tool. Looking strength. How did you do that? Asking questions. When you listen to this narrative, happened this and that happened and that happened. And then after a while, of course, you need to give people some time to talk, but then how did you manage? How did you survive? Which is true. I'm not making it up. He's sitting here. That means he made it. Something. And it happens every day. It happens every week. And sometimes they say, I don't know. Well, that's all right. Let's talk about it. What do you do? Or what helps you to get through? It's either faith or family or work or whatever. I'll take it all. Yes, and whatever they say, whatever coping mechanism they have, again, if it's smoking or this or that, okay, how does that work for you? How does it make you feel? Not just how does that work. What happens to your body? What does it do to your body? Well, I feel mellow. I feel kind of slowing down. Great. What else have you done? Have you tried to do to feel like that? This and that. Nothing. Okay, can I show you something? Breathing exercises, stretching, all sorts of meditate, whatever, Okay, and then, because people won't quit unless they have something else to use as a substitute. Unless they have better coping mechanisms, they won't quit what they're doing. They will be doing what they're doing. Or they could go for a while on willpower. Usually it doesn't last long, and it's miserable. Using language, definition of the problem, using and trying to use patients' formulation of patients' definition of how they say things. Or if it's especially useful in EMDR when I do that. So when you feel that, what happens? What are you thinking? Or when you remember that, what happens inside? And that is their experience. I don't need to elaborate. I did several workshops on interpreters and language, and I think it's a whole different area. I think one of the crucial things is using lay language. Using people's language and just simple, normal. Come think of it, for 5,000 years of our civilization, all human problems were described in lay language, right? It's only last 100 years that we started coming up with some resistance or neurosis or depression or anxiety. It was normal words before that, and people could express everything about them, and other people could understand. So it should be enough for us. And it makes it possible for interpreters to go back and forth. I think again, how do we make a person own the problem and be more active and have more agency is by asking questions like, we were working with Minnesota Department of Health on developing a screening tool, and our effort was to keep it as small and short as possible, to have a screening tool, not a diagnostic tool. And that means they need to pack a lot of things in those few questions. At this point, we were able to reduce it to 5 questions, which I think is reasonable. I would like to have less, but maybe that's enough. But one of the features of asking questions is asking, do you feel sad too much? Or do you worry too much? Because if you ask people if they're a refugee, if they feel sad or worried, everybody feels sad or worried. Or if you say, do you feel very, very sad? They may feel very, very sad, but it may be appropriate. When you ask too much, you have them acknowledge that their coping is insufficient to the stress, and there's a discrepancy, and they need help. That's where we come in. So by going in this direction, we're creating a request, or sort of an initiative, motivation for therapy. We're creating a patient by developing this discrepancy. Again, we talked about agency. I just believe that it's always there. It's just we need to find it. And that's how we start. And you can ask specific questions. Physicians in our clinic once asked me, well, what are the best strategies to go about when a patient starts freaking out? They have a panic attack, they extremely sad, sobbing or whatever. They've been there before. Whatever happens in our office happened before, and they have somehow survived it. So they know something to do, and then we need to ask them and to start. Maybe it's insufficient, maybe it's not, but that's a place to start. That by asking and refocusing them on their behavior, we're not only coping with this acute crisis, we're reorienting them towards thinking, I'm doing something. And they kind of start going into exploring more ways of cope. Although we often offer the brilliant things and patient agrees with it, we need to work on that. Can I offer something? And if patient says no, we need to respect that. But if they accept, we as professionals, that's our skill and expertise comes in. We have things to offer, and we teach them to do other things. At the same time, a lot of the time, even though we offer brilliant things, they may not accept it. And I think it's very important to ask, will you do that? Although they said it's good and nice and it's working. And a lot of the time you'll hear no. Why? Because I don't have time, because I forget, because there are so many other things, because I don't believe anything will help me, because, and you have all sorts of other questions. And you have to be respectful of that and then work from that. Okay, let's do something else. Well, let's see how we can work with that. But I think commitment to treatment is essential, and that's how we get it. So I think in the process of doing all this, we can move ourselves from patients who are not interested in living, patient who says, all I'm waiting is to die, to slightly more interested in their life and trying to at least avoid pain and do something not to hurt, moving on to staying healthy and staying alive, and ultimately maybe to wanting to be alive and to investing it to improve their lives, and with all the losses, learn how to live with them and still have some hope for the future. That's it for today.
How's my sound? Can people hear me? Okay. We do have time for a few questions. I have one up here now, and we can keep bringing cards up. So here's the first question. I see the questioner asks, I see many Hmong and Karen people in my practice. Many complain of voices and spirits, and I recognize that this is cultural, but when might it not be normal? And what is the purpose of the behavior experience? So I think they're referring to your comment that what we're seeing are coping mechanisms and that they do have a
Right,
purpose.
right. Well, of course, I can't say what's normal, what's not without looking at a patient. But, you know, like Hmong, Karen, Spanish Mexicans, they talk to the dead all the time. It's we have all our, you know, family members who passed away inside of us. We do have them in our heads. And I actually use this technique to say, if somebody said, well, I lost my father, he was so supportive, he always, you know, was there for me, blah, blah, blah. Could you talk to your father? Could you remember? And you start, you know, with like, do you remember his hands? Do you remember his face? What do you remember from his face? So it's almost like hypnotic induction into some kind of a reality where a parent is there. Ask him questions. Well, close your eyes. Go ahead. Ask him questions. See what he says. And people get answers, of course, because they know their parents. They know their people, at least inside their mind. And they get answers. And a lot of people talk to their parents or loved ones who passed away, who are not, just simply not there. So I think it could be very therapeutic and very useful. Where's the line between going to sort of a psychosis? Well, look at their life. Well, look at what it does to them. Look at what are the consequences for their everyday functioning. How much it is helpful or not helpful. How much it is isolating them from, et cetera, et cetera. Use your clinical judgment. Does it answer a question? But it's all over, you know, happens very often. They talk to the dead or talk to missing people or just like you talk to God, you know.
Do we have other cards? I have one.
Yes.
I have one question. One of the things that struck me the most early on in your presentation was you were talking about how many refugees have losses that they cannot recover from.
Mm-hmm.
And you compared it to losing a limb,
Right.
and that there's no getting better from it. I'm sure that's true. And as Westerners and as psychologists, it is not our first nature to think of problems that way. And so my question is, do you have any thoughts about how to tolerate that and work with that when we are so oriented toward there being solutions and things getting better and problems being solved?
Right. And my first, as I probably said, my first step is to acknowledge that. I would just say it like that. I say, I know this happened. You lost your wife, and she's not coming back. And there's nothing you can do about it. At the same time, you're still alive. And I hope that you can manage to live with it and maybe someday get to a point where you have hope for the future. Maybe some happiness together with this pain. Just open, no, just simple. And I think people understand that. As far as how we can change ourselves, that's a whole different question. I think that as you're totally right. Big part of the problem is in us, is in our thinking. And forward, I'm okay. We're going to fix it. No.
Thank you. Do you have another? The question is, have you heard of Jen, spelled Jen, or Jen spelled Gen in the Somali culture?
Genie. Are you referring, who asking question? Genie? Well, genie, of course. Genie is a bad spirit, and sometimes people think they're possessed by genie. Yes, I've heard, but what's the question?
That was the question. Go ahead.
In the context of family members bringing someone in who says that they are, that by
Possessed.
all descriptions they're psychotic,
Mm-hmm. Well, I would go with that, and I wouldn't dispute or try to fight it. I would ask them, what does your culture do at home when the person is like that? And they would say things, and they would say, okay, we read Quran on them, for example. Well, interesting, have you tried it? Yes, we tried. Does it work? Yes, it does. Why don't you do more? Or what else can we do? And then you can get into the experience of reading Quran, and then you discover interesting things. If you ask people how it actually happens, it happens like that. A person sits in the middle, and you have, as many people, imams, that they can get, and they first ask them to remember the problem, which is totally what we do with EMDR or hypnosis or anything else. They're basically inducing people in the state of trauma, and then people talk about trauma, and then they start reading Quran on them. And this is, I'm sure, I haven't seen it, and I'm not sure I can be sort of a present, but it's by description, a totally meditative hypnotic experience, where what you do in EMDR, hypnosis, other things, you induce a person in the state of trauma, then you create conditions where his inner capacity of process this trauma is activated. Like EMDR, you do this, or you tap on the hands, you lower their level of anxiety. We have natural capacity to process trauma. It's just when trauma is too much, it's blocked because it's scary. We lower the anxiety, we do something, and people start processing. Everybody who does hypnosis or EMDR knows how it happens. You do something, and it's not you, it's them doing things. And it's the most beautiful thing I've seen. You sit there and you do this, and you ask, what do you get, what do you get? And people tell you crazy things. It starts moving. And I believe a lot of cultural practices involve this element of that. So I would use the cultural aspect as much as I can. I would never fight it, and go on with that as much as possible.
Ruth Richardson is the Director of Programs and National Strategic Initiatives for the Minnesota Organization on Fetal Alcohol Syndrome. Prior to working at MOFAS, she was the Deputy Director of Human Rights and Equal Economic Opportunity for the City of St. Paul. Ruth has a JD from William Mitchell College of Law, is a former community faculty member at Metropolitan State University, was recently appointed to the Minnesota Judicial Branch's Committee for Equality and Justice. She serves on the Minnesota Department of Human Services Behavioral Health Planning Council as co-chair for the DHS African American Birth Outcomes Task Force, and is a current public board member and past chair of the Minnesota Board of Social Work. She's also a member of the National Institute on Health's Interagency Coordinating Committee on FASD, and has presented at hundreds of sessions on issues related to fetal alcohol spectrum disorder in Minnesota and around the U.S. So please welcome Ruth Richardson.
Good morning. I'm going to start off by apologizing for my voice. I'm losing it, so I think I have about 60 minutes left for my voice today, so it will go to good use. So I'm curious to know how many of you have had training on fetal alcohol spectrum disorders before? Oh, quite a few of you. That doesn't always happen when I go out in the community. How many of you are familiar with our organization, the Minnesota Organization on Fetal Alcohol Syndrome? For those of you who might not be familiar, I'll give you a little bit of background. Our organization has its roots in the juvenile justice system. Our founder and current president is former First Lady of Minnesota, Susan Carlson. And when she was a juvenile court judge in Hennepin County, she found a pretty disturbing trend in her courtroom. She began to track the number of kids with a diagnosis of fetal alcohol syndrome or a history of prenatal alcohol exposure in their records, and what she found was about 38% of her court calendar were kids with histories of prenatal alcohol exposure. And what she described was a revolving door. She was oftentimes seeing the exact same kids over and over again for doing the exact same things. So she went to Governor Carlson and asked, what is Minnesota doing about fetal alcohol syndrome? And at the time, there was nothing being done in Minnesota or around the U.S. Governor Carlson started a task force to study the issue here in Minnesota, and after he left office is when Susan started our organization. Our mission has been the same since inception. One, it's about prevention, because this is a disability that can be prevented. If you don't have prenatal alcohol exposure, you won't have children born with this condition. But it's also about identifying this population and ensuring that they get the appropriate supports as early as possible so that they can have the best life outcomes possible. Identification of this in Minnesota is really difficult. The Centers for Disease Control estimates that each year there's over 7,000 babies born in Minnesota alone that are exposed to alcohol prenatally. The number of diagnostic appointment slots that we have in Minnesota to actually go in to be evaluated and assessed for an FASD, we only have about 800 of those appointment slots each year. So there's a disconnect. When you're thinking about 7,000 babies being born each year exposed to alcohol in Minnesota and just over 800 appointments to get an assessment, the reality is the majority of individuals that live with this condition often walk around without the value of having a diagnostic assessment. Before we, kind of get into really making the real connections between this disability and how it relates to cultural humility, I want to spend a little bit of time just talking about what FASD is so that there's a baseline understanding for all of you with what we're talking about. And when you're thinking about fetal alcohol spectrum disorders, you can think about it in really simplistic terms as a form of organic brain damage. It's a brain injury. It's permanent. It lasts a lifetime. It can't be cured. Individuals who live with this disability will live with it across their entire lifespan. And as the name implies, fetal alcohol spectrum disorders, it's a spectrum condition. If you've met an individual with an FASD, that's all you've done. You've met one individual. The spectrum looks so different across individuals. Sometimes we're talking about individuals who are so profoundly impacted that they are never going to live alone. They're going to require constant care, 24 hours a day, 7 days a week. On the other end of the spectrum, we have individuals who look typical. They look neurotypical. They don't look as if they have a disability. But what they have is that invisible brain injury. And that invisible disability creates real challenges in our community in terms of being able to identify this population and to effectively work with them as well. When you think about the impact in our communities in terms of who's most likely to be impacted by prenatal alcohol exposure and fetal alcohol spectrum disorders, people are often surprised to hear the demographics of the women most likely to continue drinking even after they recognize they're pregnant. For the demographic most likely to continue drinking are women between the ages of 35 and 44, college educated, and households making over $50,000 a year. And that tends to surprise a lot of people because when they think of this condition, they tend to think of poorer communities and communities of color. And that it happens there as well. We see prenatal alcohol exposure across all races and across all socio and economic classes. But one thing that you'll notice about our logo in the upper corner of the PowerPoint there, you'll notice it's an upside down wine glass. That was very intentional on the part of the organization when it was founded to really think about reaching that demographic of women most likely to continue drinking. When I talk about the number of individuals impacted each year, the number of babies born exposed to alcohol prenatally, we really begin to understand that those numbers are estimates are very conservative. There has been no real good prevalence data at the national level when we're talking about how many individuals are living with this condition. And 4 years ago, the National Institute of Health commissioned a study, along with some other partners, including the CDC, to begin to look at what is the prevalence of FASD within the United States. And because there's a real lack of diagnostic capacity, not only in Minnesota, but in the US as well, they had to do a pretty narrow study. So what they looked at was the impact on elementary school age children in grades 1 and 2 across the U.S. They've been looking at many communities across the U.S. And some of the initial research has come out of that study, and they're estimating conservatively that there are as many as 1 in 20 U.S. school children within the U.S. that have fetal alcohol spectrum disorders. We're not talking about prenatal alcohol exposure, we're talking about a diagnosis of FASD. So this is a condition that is very prevalent, but it's not one that you often hear about. So being able to have the opportunity to speak with you all today is a really important first step in being able to more effectively address this in our communities. So FASD is not a diagnosis, and I won't talk about how it's diagnosed, but if there's questions during the question and answer period, I'd be happy to talk about the diagnostic process. But what I want you really to understand is the impact that alcohol has on a developing baby and on a developing brain. So the most severe outcome of prenatal alcohol exposure is the brain injury. But it can also cause many physical issues as well. It can affect the eye, the vision, the organs, the heart, bones, kidneys, the teeth. You can see birth defects, things such as cleft lips or cleft palates as a result of prenatal alcohol exposure. The work that I do related to FASD is professional, but it's also very personal to me. I have a younger sister who lives with this disability, and I feel like I've learned more about FASD from growing up with her than from any textbook or from any research out there. And when she was first born, she was severely premature. And that's a byproduct that's often seen with kids exposed to alcohol prenatally. She has a heart defect. Her lungs were severely underdeveloped, and she has breathing problems to this day. She spent the first 6 weeks of her life in intensive care. And ultimately, when she came home with us, she was on a heart monitor for the first year of her life. We all had to learn infant CPR, and we all had to be on high alert in case anything happened. And at 10 years old, being taught infant CPR is a really scary thing to go through, because I was hoping no one was ever going to trust me with that if there was something that happened. In addition to the physical concerns that she had, she was also a child that could not be consoled. And when you think about bringing a newborn baby home, there is an adjustment period with any infant, regardless of disability. But when you think about a child that maybe sleeps only 2 to 3 hours a night, and the rest of their waking hours are typically spent screaming, there's a huge challenge in terms of the care when you're thinking about kids exposed to alcohol prenatally. Our family was lucky. I had 2 parents, I had 6 other brothers and sisters, we all took a shift. So it was never too much for any one person, but understanding some of the physical challenges that can be seen with the population is really important as well. With 3 of the diagnoses on the spectrum, because you can really think about FASD as sort of an umbrella term, and under that umbrella, there are 4 medical diagnoses. With fetal alcohol syndrome, partial fetal alcohol syndrome, and alcohol-related birth defects, you're going to see some physical manifestation of the disability. You'll see things like either the birth defects or the facial malformations that can be seen. AR&D, alcohol-related neurodevelopmental disorder, that's the real invisible disability that I was talking to you about. Those are the kids who look very typical, but they've got that invisible brain injury. And I think that this picture shows you just how invisible that this disability can be. All of these individuals were exposed to alcohol prenatally, and they're all on the spectrum. And I would challenge anyone in the room to see one of these youth or young adults walking down the street and go, well, that's what a brain injury looks like. So really being able to keep in mind that invisible disability piece is really important. And also keeping in mind that people are not their disabilities. They're a lot more than that. And pictured here, we've got great artists, we've got great speakers and writers, great mechanics, and they're individuals who, with appropriate support, many of them are having a really, really successful life. I won't spend a lot of time talking about cultural humility, because I understand that you just had a really a good overview of that. But when you're thinking about what cultural humility requires and thinking about it with the lens of fetal alcohol spectrum disorders, one of the most important things is understanding and ensuring that there is understanding of this population. understanding what the symptoms may present as, what the challenges may be, and what are the appropriate supports and interventions that are going to help people have the best life possible. Another important piece is really thinking about addressing the power imbalances. And one of the things that we really focus on at MOFAS is ensuring that people who are most affected by this disability have a seat at the table, and that they're part of the solution, and that it's not about figuring out what we think that people need and putting it onto them, but rather making sure that they are at the table as well. One of the real challenges to addressing, and I think even getting to an understanding of this condition within our community, is the fact that there is a lot of stigma associated with fetal alcohol spectrum disorders, and there's a lot of stigma associated with prenatal alcohol exposure. My sister, who lives with this, and she has, challenges through school, and even now as an adult, she has lots of challenges with employment. She lives with this, and she oftentimes does not want people to know that this is a condition that she lives with. When she was in school, it's something that she hid from her teachers and she hid from her classmates because her greatest fear was people thinking that she was stupid or that she was dumb, or in her words, she was afraid that people would think that she was crazy. So she spent a lot of time, and to this day she continues to spend a lot of time trying to hide this. And when you think about it, what's more outside of your control than what happens when you're a developing baby? And if people who live with this disability don't want people to know that, what do you think happens to birth mothers? Women who have a child that has been exposed to alcohol prenatally. There's a lot of shame, there's a lot of stigma. And the shame and stigma, that keeps people from getting help. That keeps people from asking for help, and that keeps people from disclosing what the challenges may be oftentimes. And we know that FASD is a complicated public health issue. It's not about shaming women, it's not about blaming anyone, it's about understanding some really practical realities. First, I'm assuming that many of you may know what the unplanned pregnancy rate is for Minnesota or the United States, but for those of you who don't, about half of pregnancies are unplanned within Minnesota and within the United States. And when you think about unplanned pregnancies, it's possible that a woman would be consuming alcohol before she even recognized the fact that she was pregnant. And if you're thinking about women who are living with substance use disorders or struggling with alcohol addiction, the unplanned pregnancy rate for those communities are about 85%. So unplanned pregnancies definitely play a role in this disorder from a prevention and from a support perspective. Another challenge is if you're talking about someone who's living with a substance use disorder, it is not as easy as saying stop. Don't do that. Don't do that anymore. Don't do that while you're pregnant. We know that there are many reasons that it is difficult to address chemical dependency in our communities, and things like trauma, poverty, and abuse play a really big role in being able to really address that effectively. But another big challenge within our communities are our providers. Not all of our providers are giving women the same messages about the risks associated with drinking during pregnancy. Some providers don't talk about it at all because it's an uncomfortable conversation to have. And we'll hear doctors say, well, we don't want people to think that we're blaming them or shaming them, so they won't have that conversation. Some doctors are telling women that it's okay for them to drink alcohol while they're pregnant. My sister, who lives with this every day, and I think in many ways she's a success story. She's married, she has children, and there are definitely challenges there, but she's doing well with a lot of support. But 3 years ago, when she was pregnant with her daughter, her doctor told her it was okay for her to drink. He said that she struggles with anxiety, and so what he suggested for her anxiety was a glass of 2 of wine a week. He said that that wouldn't be harmful, and that would help to relax her, and that would help to alleviate some of the anxiety that she was experiencing. And so if you have providers who are telling women who live with this condition that it's okay for them to drink, that creates a really complicated public health issue for our communities in terms of really being able to address this as well. This photograph shows worst case scenario, what can happen as a result of prenatal alcohol exposure. This photograph is very rare, and I like to show this photograph because I think a lot of times there's a misconception that individuals who live with this condition, that their brains look like this. It does not. This infant was so impacted that they could not survive. And what it shows in terms of the impact of alcohol on the developing brain, it decreases the number of cells in the brain. And if you've been following anything about the Zika virus, one of the symptoms they talk about is microcephaly. Smaller head size, smaller brain size. Microcephaly is a common condition that's also seen in individuals on the fetal alcohol spectrum. And what's really interesting is when kind of the news really broke in the United States about the Zika virus, the amount of money that was spent on Zika in the first 6 months for the handful of cases here is huge compared to what has been spent on fetal alcohol spectrum disorders in probably the last 20 years, just to give you a little bit of comparison. But that smaller brain size is a common symptom that is seen with FASD. It also impacts the normal formation of the brain, the typical formation. And when you think about the highway of the brain, which is right down the middle, the corpus callosum, in really practical terms, if the processing center, if the highway of the brain is impacted, it means it's going to take individuals that are impacted longer to process information. So when you are talking with them, giving them directions or asking questions, it's going to take them longer to process that information. And if we're not adjusting the rate at which we're speaking to people who have processing impairment, they may only be getting every fourth or fifth word of what you're saying. And when you think about even giving people the time to respond, if you don't give individuals the time to process and respond appropriately and productively, and you're trying to push for that response, a lot of times you're going to get communications that don't tend to make a lot of sense, or they're not productive communications, or you'll see outbursts because individuals sort of feel stuck. It's important to understand with this condition that for some individuals on the spectrum, they oftentimes can sound much better than they're able to comprehend. And my sister is an example of that. A few months ago, out of the blue, she called me on my cell phone. And when I picked up my cell phone and said hello, she blurted out, "I'm working on being less impulsive." And I thought, okay. That's great, because impulsivity is something that she deals with a lot, and a lot of individuals on the spectrum are impulsive, and it's something that oftentimes gets them into trouble. So I asked her, I said, "So what are you doing? What are you doing to be less impulsive?" And she responded back and said, "I'm working on being less impulsive." And we started down this really circular conversation, because what I wanted to know is whether she really knew what it meant to be impulsive, and whether she really truly had a plan not to be impulsive in the future. And after about 10 minutes of that circular conversation, I said, "Okay, when you wake up tomorrow morning, what's the first thing that you're gonna do to be less impulsive?" You know what her response was? She's gonna work on being less impulsive. And so that conversation told me a few things. One, someone had told her she was impulsive. She is someone that can repeat back things that she hears other people say, and she sounds really good when she's doing it. What's better than hearing, a client saying, "I'm working on being less impulsive," if that's something that they need to be working on. But then when you see them continuing to be impulsive, the question becomes, well, are they being oppositional? Are they being defiant? Are they not doing what they said they were going to do? In her case, because my sister continues to be impulsive, I know that she doesn't know that next step. She doesn't have a plan for that next step not to be impulsive. So as I continue to see her being impulsive, it's that reminder to me that even though she sounds really good as she's saying these things, it doesn't necessarily mean that she knows what that next step is. And so then you really begin to reframe the conversation from you're being defiant, or you're being oppositional, or you're not following the rules, to do they really have the tools that they need in order to understand what's required of them, and do they need some additional support to be able to get to that next level? When you begin thinking about processing speed from the perspective of individuals getting every fourth or fifth word, the most recent example of that with my sister was when she was at United and she shut down the entire mother-baby center unit. When newborns are born, they put the little leg bands on their leg, and they're for protection so that you can't switch babies or you can't leave the hospital with someone else's child. You're not supposed to remove those, nor are you supposed to remove your armband because they really need to be able to match you to both mother and baby. Well, after being told not to remove that leg band, my sister removed it. And it shut down the entire mother-baby center. No one could get in, no one could get out, and they had to secure everything and make sure that everyone was okay. And my daughter happened to be there when that happened, and when we were talking afterwards, she said, "Mom, I don't understand why she did that. They just told her not to do that." Why did she do that? Well, the first thing, don't ask why. If you see someone do something that doesn't make any sense to you, you're never going to get a good reason as to why they did it. You're not going to get that. But for her, being told not to do it, that can actually sometimes for her be a trigger for her to do the thing that she was just told not to do. But also knowing the amount of information that the nurse was probably throwing at her at one time. My sister's not someone that's going to stop someone and say, "Wait, this is too much, slow down, can you repeat that?" She's going to smile and she's going to shake her head. And she's going to mask her disability because she doesn't want anyone to, again, think that she's dumb or she's stupid. So this photograph for me is always that reminder to have patience and to remember that our brains are different. All of our brains are different, and we all think differently, and we all process things differently. And we need the space and grace to really understand that we all process differently and at different speeds. The level of care for this population varies, as I talked about in the beginning, because sometimes we're talking about kids who are very profoundly impacted. The little one pictured there is Brandon, and this slide shows all of the different systems, doctors that he was touching in just the first year of his life. So between the ages of 1 and 2, this was his family's reality. Brandon is pretty severely impacted, and he requires doctor's appointments typically 3 to 4 times a week for all of the challenges that he has. And what's really interesting about Brandon and his story is Brandon was adopted by a family that, from the outside, had everything going for them. His mom is a medical professional. She understands FASD. His dad is also a professional. They have resources. They have family support, church support, community support. They knew how to navigate all of these complicated systems that are oftentimes challenges for families to navigate. And they had adopted children before with an FASD. So they really felt that they were prepared when they brought Brandon into their home. And what they actually have shared is raising and caring for Brandon has brought their entire family to their knees. And this is a family with all the resources that they need. So what do you think happens when you have this level of support and you take away that 2-parent household? You take away resources, transportation, community support, family support. You've got a child with this level need of care, and you throw in poverty. You throw in abuse. You throw in chemical dependency. We all know that the outcomes are going to look really poor in those situations. And one thing that I like to talk about when I get the opportunity to speak is for the families and especially for the caregivers, when you're talking about the ways that brain injuries can manifest themselves, without understanding, many people look at caregivers of kids with an FASD and they think they're poor parents because they can't control their children. And that happens not only externally at schools and in the community, but within their own families as well when there isn't a real understanding of the disability. This gives you an idea of some of the symptoms that can be seen, that are commonly seen with individuals on the spectrum. And I won't read through all of these because you have them in your handout, but there are 2 that I want to spend a little bit of time talking about. One is a difficulty picking up on social cues. Because the difficulty picking up on social cues creates real challenges within our community, and it's actually a risk factor for this population when they can't pick up on social cues or read social situations. When we are in elementary, middle school, and high school, what's most important to us when we're that age and we're in school? Acceptance, friends, feeling like you're a part of something. And when you have individuals who have difficulty picking up on those social cues, oftentimes these are the kids that end up being isolated. Because kids begin to pick up on the fact that they're not quite tracking social skill-wise. And when those kids are isolated, it creates risk factors because at that age, bad attention is better than no attention at all. And these are kids that are often at risk of being taken advantage of by individuals who prey upon them. Because when you don't have any friends, negative influences can pick up on that. And oftentimes these are the kids that are being told in school, do this or go do that. And they're wanting that acceptance so bad that they follow through on those things. And what the research tells us about contact with the criminal justice system for this population, about 60% of individuals, adolescents and adults on the spectrum will have some contact with the criminal justice system at some point in their lifetime. And what happens in jail or prison if you don't have the ability to read social situations or social skills? That typically results in these individuals being victimized, taken advantage of. And so understanding that difficulty picking up on social cues is really important. Sensory processing disorder is also another important symptom that we commonly see within this population. And a lot of times people will talk about the behaviors that they see in kids on the spectrum. And if there's a behavior that you see that's going on, my first recommendation to people is what's going on in the environment that could be leading to that behavior. I want you all to think about a situation where you've been in, where you felt that sensory overload feeling. You have felt that there's a lot that's going on in a situation, and it's impacting you. It's uncomfortable. That situation for me was when my kids were younger and they wanted to celebrate their birthdays at Chuck E. Cheese. That is the sensory overload feeling, because you're walking into a kiddie casino with the lights, the bells, the whistles, and there's kids running and there's kids screaming. There's so much that's going on there. It's an overwhelming experience. But I would say to myself, you are an adult and you will hold yourself together for 2 hours so that your kids can enjoy this party. You can do that. And I'd always do the countdown with them so everyone was prepared, when it was time to go. Because it's like, okay, 10 minutes, 5 minutes, okay, now we're leaving and we're not gonna do this again until next year. But understanding that for some individuals, they don't have that self-awareness or that knowledge to be able to say, oh, I'm feeling overwhelmed by what's going on. So if your life feels like walking into that Chuck E. Cheese every day, but you don't have the language to explain what's going on, and you don't have the ability to self-regulate, you're going to see behaviors in that situation. And Chuck E. Cheese is an extreme example. It doesn't have to be extreme examples for this population. Fluorescent lights can be something that are triggering behaviors. The fan from a projector, the tags on clothing, seams on socks. So understanding if you have individuals who are very sensitive to their environments, that's something that needs to be understood so that it can be addressed, and we can change the conversation from talking about how bad the kids are to what are the supports that they're going to need. It took our family a really long time to understand we were not going to change the brain injury. That's permanent. That's irreversible. So guess who gets to change? We do, because we have the ability to understand and to be able to appropriately support and accommodate. The movie Big, I might be dating myself here, but I think the movie Big is a way of thinking about FASD in really simple, practical terms. So the whole premise of the movie is you have Tom Hanks, who's in his early 30s, and he has everything that you would expect a 30-year-old man to have. He's got a girlfriend, a job, he has money, an apartment. But throughout the entire movie, you see him doing things that make absolutely no sense to the people around them. They can't figure out why he's behaving in that way. Once you recognize the fact that he has a brain of a 13-year-old, it becomes clear. We have really different expectations for 30-year-old men than we have for 13-year-old boys. And because of that, when you think of the symptom dysmaturity, there are a lot of individuals with an FASD that have that symptom of dysmaturity. They present much younger than they are chronologically. There are lots of overlapping characteristics related to FASD, and I think that that also is one of the challenges to us really understanding and being able to effectively address this. My sister had her first diagnostic assessment before she started kindergarten, which is great because early intervention is what we all preach. The earlier we can identify these things, the earlier we can get the appropriate supports. Her first diagnostic assessment resulted in a diagnosis of ADHD, and she was prescribed, I think it was Ritalin. The medication that she was given didn't help. It actually, her behaviors began to escalate. So my parents decided, well, we're not going to give her that medication anymore because this doesn't seem to be helping, and she was reassessed. And she was given a diagnosis of oppositional defiant disorder. Those interventions were not working. She was reassessed, and she was given a diagnosis of reactive attachment disorder. Those interventions were not working, so she was reassessed, and then she was given a diagnosis of conduct disorder unspecified. And what happens with a lot of families is that they get on sort of this wheel of assessments, try this medication, try this treatment, and nothing seems to be working. I was looking at a file of a young woman who was seen at our clinic recently, and at age 6, she has 11 different diagnoses. The 10th diagnosis that she was given was bipolar. And then the 11th was FASD. And I'm thinking, I don't think that the 6-year-old has bipolar. But it's in recognition that there are lots of symptoms related to FASD that can look like a lot of other diagnoses. Things like autism, oppositional defiant disorder, bipolar, there's lots of overlapping characteristics. The impacts of trauma can look a lot like FASD as well. And we work with a fair number of families who have adopted internationally. And when you think about kids from Russia, some who spent their formative years in institutions, that can look like FASD too. And so as we're looking at kind of these characteristics from a clinical perspective, FASD is supposed to be a diagnosis of exclusion. You need to exclude out all the other things that can look like FASD before you would get to that diagnosis of fetal alcohol spectrum disorders. And with some of these kids, it can be really difficult because it's not uncommon to see kids with 15, 20 different diagnoses. And then when we talk about treating the whole person, where do you start? And if we get stuck on the mental health aspects of the mental health diagnoses, you're never going to get to actually treating the person, because understanding the brain injury is a medical condition, and if that isn't addressed, these are individuals who will look like they are never stabilized. And we have a lot of providers who focus on, well, before we can get to the developmental disabilities or those issues, we have to stabilize from a mental health perspective. Well, if FASD looks like a mental health condition, when will the individual ever be stabilized to really begin to address the underlying brain injury? There needs to be more done to change the paradigm around IQ and intelligence. The IQs that we've seen within the community, we've seen IQs in the low 20s. The highest known IQ with someone with an FASD on record is 143. And the young woman with an IQ of 143 is currently serving life in prison in Tennessee. She was sexually exploited and sex trafficked, and at age 16, she killed a buyer. She killed a John. And one of the things that the court spent a lot of time looking at during her sentencing was her IQ. And what the judge said to this young woman was, you have a high IQ, and you could have had your pick in life of what you wanted to do because you were really smart. And you made really bad decisions. So this is on you because you were smart enough to know better. How many of us know someone with a really high IQ that has no social skills? How many of us know someone with a really high IQ, but they seem to be failing life? They make bad decisions about everything. They can pass a test, but they're failing life. They make bad decisions about work, money, relationships, and you just sort of see that one bad decision after another. And so really being able to understand that IQ is not necessarily going to be correlated to social skills or not necessarily correlated to adaptive functioning and life skills. There's no magic bullet when we're thinking about understanding this population and being able to address this as a community. And one of the things that we have to get really comfortable with when we're talking about brain injuries in general is inconsistency. I like to say with FASD, what you will get is a consistent set of inconsistencies. Expect that. And if you get any form of consistency, celebrate it. And when you think about how inconsistent brain injuries can be, it creates even challenges for access to diagnostic appointment slots. When I talk about the 800 slots that we have here in Minnesota to assess people, those aren't all for new diagnostic assessments. Because this is such an inconsistent disability, there are reassessments that are required every 2 to 3 years. So we're talking about even less diagnostic capacity for diagnosing new cases year after year. And we've seen individuals who have been evaluated and their IQs will go up 30 points, they'll go down 30 points, looking at the reassessment piece. And that's because when you're evaluating these individuals, you never know if you're getting the best version of them that day or the worst version of them, or somewhere on that spectrum. And when you think of like conditions such as Alzheimer's, it's not a one-for-one exchange, but there's some similarities. If any of you have ever dealt with someone who's lived with Alzheimer's, I've lived with that as well, you see that inconsistency. Inconsistency with memory, short-term and long-term memory. You see individuals who one day can appear fairly calm and baseline, and then the next minute they can be raging or angry or become violent. And so understanding that inconsistency piece is really important. Because a lot of times what we do in our communities, if we see the best version of someone, we expect that they can bring that best version every single day. You know how to do it, you did it yesterday. That is not what you're going to get with this condition. And I think back to when I was helping my sister with her homework years ago, and I'd help her with assignments, and one day she'd master something, and she'd bring the same assignment home the next day, and it was like we're starting from ground zero. And I cringed to think of like the things that I said to her when I thought that she was intentionally not doing her homework. But being able to understand that inconsistency piece is really important. When you think about some of the strategies, these are in your handouts, and there are definitely lots of other curriculums if you're interested in getting more information on really helping to support the population. But one of the most important things is structure and routine. The more structure and routine, that's when we see the best outcomes with this population. When individuals know what's coming next, it helps them to self-regulate. I was talking with a woman who drives a bus here in the Metro for kids with autism, and after one of my trainings, she came up to me and she said, I was driving the bus one day. I had 15 kids on the bus, and I had a couple kids that were absent. So I decided that I was gonna change the bus route because I was gonna shave some time off. So she decided to change the bus route, and she went left instead of going right. And as a result of that, you know what happened? The entire bus melted down simultaneously because she was doing it wrong. And she said it got so bad that she had to pull the bus over, and these were elementary school age kids. These were little kids. She had to pull the bus over and call for backup because she could no longer safely operate the bus. And that was just from turning the wrong way. That ruined these kids' day, probably their week. And so being able to understand that role that consistency can play with this population is very important as well. Person-first language is also something that we need to embrace when we're talking about all individuals. Many times we'll hear people refer to individuals on the spectrum, and they'll say things like, that FASD kid or that my FASD child. And I think about other conditions that we live with. How many times have we heard someone say something like, my cancer mom, my cancer sister? Like, those are things that you don't hear. And part of that, I think, sometimes is tied up in the stigma of the condition. So remembering that your language matters, your words matter, and that people are people first. And when we think about, this again in terms of from an equity perspective, there are some really serious equity challenges with this population. To start off with, there's not enough diagnostic capacity for individuals who want it. And for families to have to wait 6 months to a year to get a diagnostic assessment, that's something that is really unacceptable. When you talk about a population where 60% of the population have a disrupted school experience, and that's everything from suspensions, expulsions, learning difficulties, truancy, and bullying, and then a population that 60% come into contact with the criminal justice system, well, that speaks to a whole school to prison pipeline for this population that needs to be addressed. And that, again, that's a justice issue. That's an equity issue as well. Employment challenges are common with this population, trouble finding employment, being able to maintain employment, and housing. Those are all of the, not all, but those are many of the equity challenges that this population is facing. And these are persistent disparities that we're seeing. There's also disparities in terms of life expectancy. There were a number of studies that were recently conducted, and this is initial information, so there definitely is a need for more research. But looking at the life expectancy for individuals with fetal alcohol syndrome specifically, and what they found for individuals with FAS, a life expectancy of 34. And when you begin to look at what were the common causes for early death, one of the most common, suicide. Because when you think about a population that maybe spends their entire life hearing about how bad they are in every single aspect of life, from school to employment to maybe even home with family members, you can see a lot of poor self-concepts. Because if people don't really understand the disability, if they don't understand that this is related to not intentional behavior, but to a brain injury, you see a lot of poor self-concept and you see a lot of depression within the population. And if you don't fit in, and you're isolated and you're excluded from your communities, those are things that lead to those poor self-concepts. Some of the other common leading causes of death included things like heart defects, and also sort of increased proneness to infections was another common challenge that was seen with the population as well. And here's a list of some of the secondary disabilities that are often seen within the population. The primary disability is the, FASD. These are a lot of the challenges that you see if you don't have the appropriate interventions and supports in place, and if there are not FASD-informed providers and schools and communities who really understand this. Awareness is key, and even thinking about that whole concept of the school to prison pipeline, I think the story of Colton Harris Moore is an important one. Colton is also known as the Barefoot Bandit, young man with an FASD, and his claim to fame was stealing an airplane and crash landing in the Bahamas. And when he stole that airplane, it made international news because everyone wanted to know, who is this guy that stole this airplane? That is not the most interesting thing about Colton. I think it's more interesting that it was the 7th airplane that he had stolen and the 7th airplane that he had crashed. So you're really talking about someone getting stuck and doing that same thing over and over again. And there was an FBI agent who was central in his capture who gave an interview after Colton was captured in the Bahamas, and he said that Colton Harris Moore is a criminal mastermind and he's been committing crimes since he was 7 years old. And that comment really stuck with me because I wanted to know what makes you a criminal mastermind at 7 years old. So I looked that story up, and it's all online, and people can find this. But Colton's first interaction with law enforcement in his town, it was the local sheriff in his town, he had gotten in trouble for breaking into his neighbor's house. He stole food, water, clothes, and shoes. So when you have a 7-year-old who's breaking into their neighbor's house to steal food and water, I don't think that you have a criminal mastermind. I think you have a kid that's not having his basic needs met at home. And when you had the opportunity, if you have the opportunity to see some of the video of Colton's mom, who actually just recently passed away, but on the interviews that she participated in, she presented as a woman who was having challenges caring for herself, let alone being able to care for someone else. She struggled with alcohol addiction for most of her life, had experienced a lot of trauma, had experienced a lot of abuse, and Colton oftentimes was left to his own devices. And as a result of that, the way that he saw to be able to care for himself, starting really early, was breaking into his neighbor's house to steal food and water. And after a while of stealing food and water and clothes and blankets from neighbor's house, it escalated to he began to steal money from the neighbor's house as well. And there was one instance when he had broken into one of his neighbor's home and he had stolen money. And when he was going down the street, he came across an animal shelter. And Colton loved animals, so he decided to break into the animal shelter to leave this money for the animals. In addition to leaving the money for the animals, he left a note, and he said, "I thought the animals could use this money. Love, Colton Harris Moore." I don't think we're talking about a criminal mastermind from that perspective. Being able to understand that really being able to address this early is going to be the key to better outcomes. Colton was a kid who never had any services, no school services, no waivered services. The first time that he got services was when he was in a federal prison, and that's backwards. One other quick thing that I just want to talk about before we can open up things for questions, but understanding that this population is at high risk of getting into trouble with the law, but they're also at the same risk of being victimized. And in many ways, sometimes they're at much greater risk of being victimized. And the woman pictured there is Carly. In that picture, Carly is 41, she's 43 now. And Carly has the developmental age of about a first grader. And her story is, I think, a very heartbreaking story about how individuals with intellectual disabilities oftentimes don't get equal access to justice. Carly was sexually assaulted in her early 20s by a cab driver from a service that had been hired by their city to transport people with disabilities from home to employment. So a lot of times, many times where this population is being victimized are in places where you think you should be safe. You know, being transported by a cab service, you hired specifically to work with that population, you would think you'd be safe there. Instead of taking her to work, the cab driver drove her to a park, assaulted her, and then dropped her off at work. And he then collected the $1 that Carly was required to pay for the transportation services. She did everything that she was supposed to do. She told her supervisor, they got her parents involved, law enforcement became involved. Law enforcement found her story credible. Ultimately, the county attorney decided not to pursue the case because they didn't really see Carly as someone who was going to be able to string things together in a way that was going to result in a conviction. And fast forward a few years later, Carly is sexually assaulted again by another cab service provider. And in that case, the family really went to the wall on that, and charges were brought, and that individual was ultimately convicted. But what was very sad about that is during the trial and afterwards, it became very clear that there had been several complaints about similar experiences that other young women had experienced, and nothing had been done. So really understanding the fact that equal access to justice is something that is very important for the population as well.
Okay, Dr. Gorno graduated from the University of North Dakota with a PhD in clinical psychology in 2002. And she's the clinical director of the American Indian Family Center, managing mental health, chemical dependency, and women's health programming. She's also an adjunct faculty member at St. Mary's University. She is an enrolled member of the Turtle Mountain Band of Chippewa and is passionate about helping people to heal. She's a member of the American Indian Mental Health Advisory Council, which provides recommendations and advises the state of Minnesota on mental health issues that impact the American Indians in the state and ways in which the state can provide support to that community. Dr. Gorno specializes in the treatment of complex trauma by combining Western and traditional American Indian perspectives and methods to assist people in their own healing process. In addition to providing and guiding mental health services, she is also passionate about educating the community at large about American Indians and the issues that face them in contemporary society. Dr. Gorno provides education and guidance to young professionals through teaching of graduate classes and by providing supervision to guide them in development of their therapeutic skills. So please welcome Dr. Jessica Gorno.
Thank you very much for that warm introduction and to be able to have the pleasure and the honor to present to you today. As Dr. Fisher has mentioned, I am very, very passionate about education. American Indian population is 1% of the United States population. However, we have the highest disparities in the United States of America and Minnesota in particular. And I find it's very interesting to present and see all the things that people generally don't have accurate knowledge about. And so I'm really honored to be here. As Dr. Fisher said, I am an enrolled member first of the Turtle Mountain Band of Chippewa. And so the perspective you're going to hear from me today is really one as an Indian person in this society and in this world at this time, but also as a professional in the field, having gone through the field of clinical psychology, and also how my views on healing and practice of psychology have changed as I've done my work. I think that's really important because I think it is an important topic for us to talk about in our field, about how we can best diversify. We have a very multicultural world we live in, so it's important that we also progress with that. I also am really passionate about finding all these providers here super interested in cultural topics, so thank you again for coming, in addition to the free CEUs, so that we're all love to get. So again, thank you for coming and for spending your time here today. You could have been someplace else, so welcome. One of the things I like to do in my PowerPoint presentations, though, is part of a quiz, and I know that most of you, if you've gone through graduate school, are probably type A personalities. So for those of you, at least in the beginning of this, please don't follow my PowerPoint. Try not to look. Some of you I know have probably already reviewed it, if I'm going to be quite honest. But try to suspend your looking forward and try to see if you can play along. I find it really helpful to have people learn about the Indians that are actually within the state of North Dakota. I have grown up in Minnesota. I have grown up in North Dakota, and I've worked on all the reservations in North Dakota, but I also have worked in the reservations here in Minnesota. And what I found when I moved here was the unbelievable disconnect I had as a Native person and not feeling tethered to the ground. That's something that you'll hear me talk about a lot, and feeling that disconnect. I assumed, as wrongly, that when I moved here that these Indians would be like the Indians I had always grown up with. And they were not. And so I felt disconnected from my family and from my tribe. When I came here, I accepted an internship at Hennepin County Medical Center in their adult track because I had already had a lot of children experience, and what I liked about it was that they understood that I was struggling with that, and so they literally had to find me a mentor to kind of guide me, which was interesting because they had mentors for people from Croatia, from Russia, but they didn't have an American Indian mentor. So they actually had to look outside the organization, but that mentorship really kind of saved me and grounded me, and I've been very, very thankful for that experience. So they located a Native woman who had previously been through their program, and she connected me to the American Indian Family Center on the east side of St. Paul, where I currently work. And it's important for you to kind of know about some of the services that are available, because Indians kind of run under the radar. We're the community that nobody really talks about. And so there's a lot of information out there that is sometimes not accurate, but also a lot of providers who just don't know where to look. And so that's really important to know that. In Minneapolis, the center that you're probably thinking of and possibly confusing with mine is the Minneapolis Center that's on Franklin Avenue. The one on the east side of St. Paul serves the Indians in St. Paul. For those of you who live in the Twin Cities, you probably get this. When I first moved here, I didn't understand why people go, oh, that's all the way in Minneapolis. That's just too far. Now, when you come from North Dakota and you drive for 2 hours for McDonald's for a burger, that's a kind of foreign concept, you know? So I didn't understand that. It took me about a year before I went, I get it now. That's just, I'm not doing all that. I'm not going to Minneapolis. It's the same thing for the natives here. They don't traditionally pass the river. So in St. Paul, the natives that want services will come to the American Indian Family Center. So it's really important for you to know a little bit about what we do. So if you are making referrals or you're looking for that context, or you just want to ask a cultural question, we're always available and willing to answer those questions. So a little bit about who we are. Now, Our mission is to provide American Indian families with programs and services that are enriched by traditional American Indian values and cultures. You're going to hear me talk about that a lot today, because when we're talking about healing on a community and an individual level for Natives, we are talking about the bringing back of traditions, values, cultures, and traditions. There are reparative institutions as well as healing institutions built into those values already, and we see those as extremely vital in helping people to heal. And I'll talk more about some of the things that we've done within therapy that has helped clients to progress at a much quicker rate than our traditional Western modalities, to give you kind of an idea. So that's why our mission is about that. Everything that we provide there is enriched by traditions, cultures, and values. When you come into our building, you should be seeing things that you don't see in other places, because we want our building to reflect the people that we serve. So for instance, when you come in, people are going to be, and this is a small thing, but it's a large thing. When people come into buildings, they need to see people who represent them. And many Indians walking into lots of places do not feel represented or seen, which then makes them feel uncomfortable and not safe, and therefore possibly not following through with services. So it's really important. What does an Indian look like? Well, you see me with blonde highlights. That's only because I have gray, and I'm trying to cover it up, to be quite honest. But Indians can have red hair, they can have blonde hair, they can have blue eyes, they come in all different forms, and people like to kind of pigeonhole that, and when they don't have that visual aid of color, they don't know. And oftentimes you guys have probably treated a person who's been Native and didn't even know it. So it's really important when we're talking about this that you think about what does an Indian look like, and start to challenge kind of some of those viewpoints you might be holding. And I'll talk a little bit about how those got formed, because they got formed for me definitely by media and other things, but definitely not my history, not my history books. So what we're trying to bring back is that positive cultural identity. So you see that our mission and our values and our visions are all around traditional values. Matter of fact, our policies are all based on the 10 Indian commandments. If you guys haven't looked on that, you can find about 1 million memes on Google that list the 10 Native commandments, and those are all based on kind of our values and our missions and what we do with all of our programming, especially our therapy programs. All right. Again, who I am, I've already talked about that. One of the things that is really disturbing and difficult for me is that to be able to teach this in the time that I have with you, I have to generalize. And I don't like to generalize, as many of you I'm sure don't either, because we work with individuals within a particular context, of course. And to just give you an idea, if you don't know this already, there is an extremely rich and variety-ridden American Indian population within the United States of America. We have over 560 federally recognized tribes, and we have over 160 state-recognized tribes, which I'll describe a little bit, because we have a unique relationship with the federal government. It's a complicated relationship with the federal government. We are actually considered sovereign nations. And do people kind of understand the idea of sovereignty? Okay, so that means that the United States government is supposed to be interacting with the American Indian tribes as if we were a different country. So we're an independent, dependent nation within the United States of America. Very confusing for you, extremely confusing for us. So one of the other things is we also have a legal definition of being wards of the state, wards of the United States of America. They've made us orphans to the United States government. So you need to understand that, because when you think about that mentality of being considered a child of a nation, that forms cultural identity and also forms some of the behaviors you may be seeing in your Native clients that you come forward with. But it's a really hard concept to wrap your mind around. So we're allowed to govern ourselves, but we're only allowed to govern ourselves within certain strictures, if you know what I mean. The minute we do something that they don't like, that can be taken away. So even though it's there, it's not there. So just to give you a little bit of that. I don't know everything. I hated telling you that one, because I want you to believe I know absolutely everything. A lot of everything that I'm going to be telling you is really my opinion and my experience and things that I have learned doing this work through the mistakes that I've made. And some of those mistakes have directly been in conflict because of things that I have been taught in graduate school. So, going to graduate school, having those discussions, trying to argue about, I'm going to date myself here, but, You know, I graduated in 1998. I came here. I wasn't graduated yet, but my training was we didn't talk about spirituality, we didn't talk about religion, and we didn't talk about those institutions. And my argument was, how can you help heal Native people if we don't have those conversations? Because it's a very integral part and portion of that. And the responses I received were just really difficult conversations. And so when I came into this, I was trying to implement my Western ideology into a cultural framework that just was not set up to work that way. So those are where I made lots of my mistakes, and I'll hopefully give you enough pointers where you don't end up making any of those mistakes either. And I talked about the incredible variety and the expanse of people. So just keeping that in mind, if you want to do more research, it's kind of outside the breadth of experience of this particular workshop. I'm sure some of you probably have a little bit of information, and some of you have very little information. But it's really important to always know that we need to really understand the individual tribe that you're working with. This is where the PowerPoint gets screwed up. I had it set up where this was supposed to nicely float up, and it's not working out. So one of the things I'll talk about is that in North Dakota, there are only 4 reservations, but in your state of Minnesota here, you have a large variety of tribal nations. So you have 11 tribal nations here within the United States, or I'm sorry, Minnesota. Can you guys name, just yell out kind of some of the ones that you know of? There's 7 Ojibwe tribes and there's 4 Lakota tribes. We got Fond du Lac, Red Lake, Boys Fort, I'm sorry, Leech Lake, White Earth, yep. Mille Lacs, yep. Grand Portage, Prairie Island. I missed one. Did anybody say Upper and Lower Sioux? I know, we always miss those ones, don't we, down in the south. But you'll have your Lakotas down in the south. So your Dakotas are your Upper and Lower Sioux, your Prairie Islands, your Mindewakan. Your Ojibwe nations are the ones you already listed, your Grand Portage, your Red Lake, your Boys Fort, your Fond du Lac, your Leech Lake, your Mille Lacs, and your White Earth. For instance, I said I'm from the Turtle Mountain Band of Chippewa. I don't know if you know this, but the natives in Minnesota consider White Earth to be the white Indians, vicarious trauma. And they consider my tribe to be like White Earth. So you'll see a lot of facial variety within those 2 tribes, but that's some of the things that other Indians will do to other Indians, interestingly enough. So that's one of the things I'll talk about later. When you refer people to places for services, you need to be careful about where you refer them to. So those sorts of things don't happen to people, because in the Twin Cities area, you have a lot of natives who may not have had a lot of exposure to their culture, and therefore really want to learn about it, and who you send them to is really important, because it's a shameful thing to feel about not knowing how to be Native or knowing what that is. So many Native people will pick up things they've gotten from movies. John Wayne, how many of you grew up on John Wayne? Did he like Indians? Guess what Indians grew up watching? John Wayne. My dad has a story, and I talk about this, and it breaks my heart, but it also lets me know that's the message I received as well. He said, when we were growing up, he said, we always played cowboys and Indians. These are Indians on a reservation playing cowboys and Indians. And he said, nobody wanted to be the Indian. And I think I knew the answer, and I kind of went, why? He goes, because everybody knows the Indian needs to die. And that was a really powerful stare. Everybody knows the Indian needs to die at the end of this. And that is a mentality that is very deeply ingrained in Indian communities, not just mine, but in all. I truly did not believe I would be alive today. I'm 47 years old, and I was convinced for whatever reason that I was going to be dead by the age of 40. Don't know where that message came from, but I wasn't the only one that felt that way. I graduated from a class of 70 on my reservation. Half my class is dead. This is within the United States of America, guys. There is a high, high level of grief and loss in our community. And I don't think a lot of people have had to go to too many funerals. The reason why I didn't have my drum group here today is because one of the drum group people had their son commit suicide. And so they are consumed with supporting him and conducting some of those ceremonies that need to happen. So that is an important kind of statistic to think about, that a lot of these Indian people that you're seeing are struggling with, and much of it is unresolved. So it's built up and built up over multiple and multiple losses. I'm going to give you another part of the quiz. So because we're sovereign nations, we weren't necessarily considered American citizens. We didn't know that, but we weren't. So it was definitely outlawed. One of the things that they did is they outlawed the practice of traditional American Indian religious practices. All right, they outlawed them, and people were actually incarcerated for any practice. So a lot of those things went underground and were practiced quietly. And that really kind of was dependent upon the tribe you were a part of. Some were able to keep more of those, some were not. So it was really against the law for American Indians to participate in traditional religious practices. What year were they allowed to practice their traditional practices? When do you think they were granted that right? 1978. When you think about that, that's not that long, right? Now, these practices were meant to be shared. So kind of give you an example of kind of some of the things you've seen in the media, for instance. Do you guys remember when all those people died in that sweat lodge in Arizona? Okay. There was a traditional leader that wrote a letter about that, and one of the reasons you'll see Native people being so secretive about sharing some of these ceremonies with outside people are directly related to this particular trauma. Because they outlawed it, a lot of the elders and people who were helping the younger people made them be quiet about it, and so they stopped talking about it, and then they started to hide it. So when it comes out in 1978, the idea is you keep those things close and you hide them, and you do not share that information with people outside your community. Now, some tribes hold that strongly, some don't. And what that elder said about what happened in Arizona is, he was very, I thought, really well thought out. He said, these were not meant to not be shared. However, when you move forward with traditional practices that are not your own, and you don't understand the meaning behind them, these things happen. You bring in. And anytime you add money, I don't know if you guys heard about how much money these people paid to go into these sweat lodges, but it was a significant amount of money. So the selling of traditional and religious practices is definitely not Native specific. So those are some of the things to think about in regards to our religious practices, because these things are very important when we talk about healing for our population. We were also not allowed to vote. Did you guys know that? We did not have the legal right to vote in the United States, and that finally got passed. What was the year where it was the last state to pass this, allowing us to vote? 1960. So very recently, in Utah was that last state, which I was surprised that. I always thought that would be North Dakota. But it was Utah. So we were finally allowed to vote in 1960, which is interesting because, I think I'm using this wrong. Yeah, I am. There was a picture here. We have a very long history of participating with the military. Did you guys know that? And what they say is, this is a way for you to get out of the reservation and have a better life. And for some people it is. You know, they do get their education paid for, but when you're talking to poverty-stricken people, the only people that come to recruit you are the military. You end up having a high level of people in trauma-induced environments, again, who are already traumatized. But if you were to ask these Native people, would they have volunteered even if they have known? Most of them would tell you yes. And there is a strong tradition of loyalty to your people and to your country, even with the relationship that we have with the federal government. So that's something important to keep in mind. Not all Native people have a negative viewpoint of that. I don't know if you knew this, but it was illegal to, when the draft came back for the Vietnam War, it was illegal to draft American Indian people because they were not considered United States citizens. But they didn't tell them that, and they drafted them, of course. They went back and did a study, and they told these people, now that you know that you couldn't legally be drafted, and you know what you know now, what would you have done? And they asked Vietnam vets. They made sure to ask Vietnam vets. 90% of them said they still would have done it. And again, that speaks to that loyalty piece of that. So even though we do have that relationship, there is a lot of pride around that. And there's still a lot of people who believe in that. So that might be kind of confusing to some people, so I always like to mention that. And it becomes even more confusing because one of the things in our history of trauma that you have to think about, which kind of shapes us today, is our history with them. The most Congressional Medals of Honor in the United States were awarded for what battle in U.S. military history? This would be the Battle of Wounded Knee in South Dakota. They awarded 20 medals of Congressional Medals of Honor for the massacre at Wounded Knee in South Dakota in 1890. I didn't put the pictures up. The pictures are a lot of you have probably seen them, but they're not nice pictures to look at. In 1890, where soldiers killed an estimated 300 Lakota people, mostly women, children, and elderly people that were on their way to a religious ceremony. The United States government and tribes are working diligently at having those Congressional Medals of Honor rescinded. They have been handed down in families, and families are fighting to keep them. That is one of the ways when we talk about reparative institutions and how we can repair our relationships, this would be one of them. And so that's something to think about. And a lot of people carry this. It's not been uncommon for me to have natives in therapy who have talked about having dreams about this massacre. So when we talk about cellular memory and how these things are kept, they are kept very deeply and personally. So that's something to keep in mind. That is not something unusual that you'll hear about. Natives believe a lot in their dreams. A Native person generally, this is one of the ones that goes across the tribal issues, is most Indians believe that if they have a dream 3 times in a row, that it means it's going to happen. So you might have some natives who come in and talk about fear that they're going to be dying because they had that dream 3 times, and so a lot of anxiety around that. And that's actually a cultural belief, so that's something to think about. I don't think a lot of people put a lot of worth in some of their dreams, or but a lot of people talk about relatives coming to visit them and about receiving messages in their dreams. So that's something that you can use in therapy as a therapeutic tool to talk about things that they might not be so willing to talk about directly. Another part of our quiz, before enactment of this federal law, as many as 25 to 35% of all Indian children were being removed from their Indian homes and placed in non-Indian homes with presumably the absence of Indian culture. Now, in some cases, the Bureau of Indian Affairs paid the states to remove Indian children and to place them with non-Indian families and religious groups. Testimony in the House Committee for Interior and Insular Affairs showed that in some cases, the per capita rate of Indian children in foster care was nearly 16 times higher than the rate for non-Indians. Now, this was a federal mandate. I have friends who this has happened to, so this is not something that is, that far gone. And so I don't know if you know this, but the Bureau of Indian Affairs was designed and developed to manage Indians, right? Hence the name Bureau of Indian Affairs. We needed to be managed. Where do you think the Bureau of Indian Affairs is housed within the federal government? Department of War. When you think about that, and you're being managed by the Department of War, so if you go on to any reservation, you will find a BIA housing. So Bureau of Indian Affairs was mandated on all of their reservations to remove children from their homes. And this is the talk where we start talking about the boarding schools, correct? So the federal government, when we talk about what you see and why children are in foster care and some of the behaviors you're witnessing now, is our traditional parenting practices included non-punitive methods of parenting. We believe that hitting a child as punishment takes apart and away a piece of their soul. So Native people did traditionally never used physical punishment with their children. Children were, and I was brought up this way, children were taught to follow everybody around, especially your grandparents and your elders and your aunts and uncles, and you learned from what they did. And if you did anything, people in the community were allowed to parent you and punish you for inappropriate behavior. Not physically, but I'll guarantee you, if I went to town and I was doing something, and you have to understand, my father, for the first half of my life, was a police officer. And his first degree was in criminal justice. Second half of my life, he was a social worker. My father, if I did anything wrong, you know how many people were telling on me before I even got home? I didn't get away with with anything. And when you think about that collectivistic way of raising children, it was really, I think back on that now, I'm like, how much of a pain in the butt, like I couldn't wait to leave just so somebody wouldn't know me. Now, not that I was gonna go and do anything bad, it was just like, any of you grow up in a small town? You know what I'm talking about. Everybody knows your business, and you just wanna go someplace and not have anybody know you for 5 seconds. And what do? I move to a Twin Cities, into an Indian community thinking, this is a metropolis area, I'm not gonna bum in it. It was crazy how many people I ran into that I still know and that know me. But that being said, you were allowed, they gave the latitude to family members to help them parent their child. When it came to the really bad discipline, my parents didn't do that, my grandmother did that. And the reason for that in traditional parenting models is so that the relationship between mom and dad and child is able to be conversational. So guess what? You can't be mad at grandma, because you can't be mad at your elder, but you could get mad at mom and dad, right? And you've seen that situation. It's much easier to have somebody on the outside holding somebody responsible than the actual parents. So I had a lot of that going on, but when we did this and we removed kids from homes and put them into boarding schools and adopted them out of families forcibly, they hired the Bureau of Indian Affairs, and the Bureau of Indian Affairs hired the Catholic Church. Okay? And they started boarding schools. What they found out is that when Indians were in boarding schools close to home, guess what? They ran home. So what they would do is they'd come onto the reservation. Just think about this as probably all of you are parents in some respect, right? So somebody comes into your home and takes your kids, and you have nothing that you can say or do about that, and they take them and you never see them until they're 18. Can you imagine that? My grandmother had 8 children, my father's mother. And when the FBI agents came onto the reservation to take the children, because you do realize that if you didn't, your parents were incarcerated, they were locked up. So and parents did go to jail for this. So what she did is she played a game. She said, we're gonna play hide and seek. And she hid the kids in the basement. My uncle was outside playing, and he got caught and he was taken. Now, she would never talk about that, but he would tell me about it. And the reason he said she wouldn't talk about it was it was too deep of a pain. It was in her soul, and she couldn't have that conversation. So the elders never really talked about that. But when he went away and came back, he was a different person. And that was your introduction of physical abuse, sexual abuse, and punishment. Because military and Catholic schools use punishment, right? Severe punishment. So guess what happens in one generation? If you don't know how to parent and you now come back, and there you go, there's the loss of language, right? So you were not allowed to speak your language either. So when you came back, you could not communicate with your family. You also couldn't parent in the same way. So now we have the introduction of alcohol and drug addiction, right? So you can see how quickly parenting can be disrupted within a generation. And with the elders not talking about it, there wasn't a platform for these people to be able to have those conversations in a safe way. So guess what? When we become parents, what do? We parent the way we were parented. So what that has led to, the state of Minnesota removes children at the second highest rate in the United States. Out of all the 50 states, it's the highest removal rate of Indian children from homes. 25% of the kids in foster care here in the state of Minnesota are Native children. Yes. We're 1% of the population, we're 25% of the children in foster care. Now, that is directly related to what I'm going to talk to about cultural identity and about making sure why this is so important, because there's a lot of people providing services, especially within foster care, that don't get this. It is very, very important to obtain and keep and maintain that positive cultural identity, to be able to anchor a person to feel safe and secure and to be centered in this world. And if you have a piece and portion of yourself you do not know or understand, you are going to struggle. You're going to be marginalized, as we like to say in our data. And what do we know about people who are marginalized? They don't do well in lots of areas. They don't graduate from school. They don't go to college. They're unable to maintain consistent employment, and they struggle in relationships. And that's why it's super important. So what they were doing is they wanted to get rid, have you guys heard about Save the Man, or Kill the Savage, Save the Man campaign? The federal government, that was an actual mandate. Kill the savage, save the man. So that was the reason for boarding schools, and that was the reason for dismantling of parenting strategies, is they hoped that we would just get absolved and be one big melting pot. That did not work. So what they tried to do was continue to remove children through foster care systems. So you'll see that Native people have a high mistrust of any sort of social service system out there for a healthy reason. So a federal mandate was put into place called the Indian Child Welfare Act. How many of you had to deal with the Indian Child Welfare Act? I'm sure, yeah, definitely. It's a complicated process. And what they found is when they put this act in place, they had to start the Indian Child Welfare Act because the judges and the legal system were not following their own law. They were actually, the law states that if you remove an Indian child from a home, you absolutely need to put them as much as possible in homes with Indian cultural heritage. So they have to be within a family. If there's no immediate family, another tribe. So this law is in place for the tribe to protect their own children. I think that's kind of crazy to think that we actually had to enact a whole department to force a legal department to follow their own law. And the reason why this is so important, if I can impress this on you, is that I have children in groups currently at the Family Center who really, really do well when they're involved in those cultural ways, but the minute they're removed from them, they start to struggle. And a lot of people in foster care go, well, why? They're in a stable home. Yes, they're in a stable home, but you're disconnecting them, and they're starting to struggle. Because I've had foster care parents who've made excuses for not wanting to bring them to the Family Center when they've been people outside the community who have found millions of ways to try to disrupt that. So that's something to be thinking about. It's really much more important than I think people give it credit. Okay, oops, I pressed something, there we go. One of the things, you guys know where and I have a spelling error, I apologize on that. Where and when did the largest mass execution in United States history take place? Mankato. And this is one of the dark periods of Minnesota's history. I don't know if you knew this, but the state of Minnesota actually used to have a fairly decent relationship with Indians up until this point. Many of the native tribes had women who were intermarried with people in legislation and had more positive relationship. But what happened here in 1862, I'm going to move forward and just show you the map first and then come back to this one. It's really, I need to change the color on this. It's really hard to see. But if you take a look, these were the lands that were ceded in that particular treaty, 1851 treaty. The little strip that you see, but what happened was much more interesting. So what happened is the federal government would delay the food. And you do understand that natives at that point didn't deal in money, so the concept of money was a very foreign concept. So they didn't really understand the selling of these things. So when you had that, a lot of the white trappers and traders and businessmen developed businesses directly around those little reservations. And so they would withhold the food. People would start starving. They'd go into these places and say, oh, we'll give you a forward or an advance on that, not telling me how much that costs, right? They'd get the forward. By the time the money would come in from the federal government for their payment for the land, the businessmen would all meet and not allow the Indians to be there and say, well, you owed us this money and take all of it. So that's how it was working. So Indians started to starve, and they had a couple of Indian men went into town to ask for food, and they were waiting for their disbursement. And they were told, let them eat grass. And had a hole full of grain thing. So what they did is these 4 Indian men went into the tribe, and they went and stole some eggs or some food from a farmer in the local area, and were caught and ended up murdering that family. When they went back to their tribe, a bunch of the tribal leaders were talking, and half of them were kind of like on the fence about like what they were going to do, and a lot of them were saying, well, they're going to come here and kill us anyway, so we might as well fight. So they did a preemptive strike, and they started the Mankato conflict. And I don't know if a lot of you heard that, but they'll try to tell you that it was a lot of these white settlers who died, and they did, but there was much more higher Indian numbers on the deaths. So what happened, and what's interesting about this, is that the federal government decided that they took away the tribal designation for, if you look at the ones that we talked about, Shakopee, right, Mindewakan, the Mindewakan community, the Prairie Island community, and Upper and Lower Sioux. Do you realize that they can't call themselves tribes? Tribes is a federal designation. The reason they cannot call themselves a tribes, they have to call themselves a community, is because of this conflict. They were involved in that, and the federal government stripped them of their tribal rights. So they can no longer call themselves a tribe, but they are a tribe, if you know what I mean. So when that happened, if you look on it's really interesting if you ever really look on your legal rules, the things that are still on statute as being allowed to do. One of the ones that we use as a joke, but is also kind of difficult for us, is there is a rule on the law books that states that if more than 3 Indians are standing together in one spot, they're called a war party, and you can kill them on sight. Yeah, so we'll literally stand around the family center and say things like, disperse, disperse, there's 4 of us. It's a joke, but it's one of those sad jokes, but it's still on the books. And if you look online, you'll find a lot of the things that offered $300 for the head of an Indian if you found it. So a lot of bounty hunters came into Minnesota at that point in time, and of course a lot of the Indians fled. So Chief Littleshell went up through Minnesota, a lot of them fled to Canada, and he actually left one of his wives on my reservation. When he came back, he didn't come and get her. I don't know if you knew this, but Native tribes at that point in time could have more than one wife for survival, because of women, if they didn't have somebody to help hunt and pillage for them, they could starve. So he had a couple of wives. That woman is a granddaughter of him, and she actually resides at the Elders Lodge in St. Paul. And she's a direct descendant of some of these, of that particular man who was involved in that conflict. So it was a pretty bloody mess. It ended with the hanging of the most people that we've ever hung in United States history. On Christmas Eve, the day after Lincoln freed the slaves, he hung the most people that he's ever hung in the United States, even to this day. He hung 38 Indians at Fort Snelling. And I don't know if you know this, but they developed a special hanging mechanism to do this that's actually on display in a museum here in the United States of America as a technological advancement. And if you ever want to see something that really kind of tells you more about this story and about ways in which we're trying to heal from this history here in Minnesota, this particular website, www.smoothfeather.com-Dakota38, is really a beautiful thing to see. But please bring a box of tissue with you. It's not an easy thing to watch. It's free. They ask for a donation if you want to, but they don't demand it. They just really want the word to get out. And this is a Indian man, a medicine man in the community who had a dream, and in the dream he kept on thinking, horses kept coming up in this dream, and he thought, we really need, and he realized the message was we needed to start healing from this. And so he started the Dakota 38 ride. How many of you have heard of the Dakota 38 March? Yeah. It is really, truly a beautiful, beautiful thing to see. And these guys ride to Mankato, or ride from Mankato they end up at Fort Snelling, and then they have their healing ceremony right before Christmas. And the reason why it turned out to be such a beautiful thing is he didn't have anything set up to do this. And when there was points and times where they actually started to freeze with the horses on this journey, and local people in the community started to take them in. And so now when they do this trip every year, there's people that always participate, and they end up with the guy in Mankato giving them the key to the city. So they're really working on ways in which to heal from this, and it's just a beautiful documentary about that. The link underneath it, I apologize. When I did this PowerPoint presentation a couple weeks ago, that link was active. It's no longer active. So, if you go to that www one, it'll give you a nice little recap of that. So I encourage you to take a look at that. That is a really good model of healing in a way in which hopefully the state can continue to heal. I love terminology. I sometimes think about, I know how I feel about this in my heart, but I don't have the words to describe it. And I've always found the saying by Maria Braveheart, Maria Yellowhost Braveheart, as for me as a Native person, explains to me what it's like to still experience trauma and not understand why. And this explanation of the cumulative emotional and psychological wounding over the lifespan and across generations emanating from massive group trauma. We truly believe that we carry memories within our DNA and within our spirits, and that gets translated into future generations. My best description of this is that, a lot of people might not understand this, but when you grow up in a tribe, it's a real good sense of belonging to something, right? It's a sense of belonging, and you know your place in the world, and there's a beauty in it as much as there is trauma in it, right? But it makes you very deeply connected to other natives, regardless if you're from that tribe or not. And I was in Seattle, Washington, and I walked into, I think the business was called the House of Curiosities or something about curiosities on that Pike Place, or where they have all the fish and everything. I walked in there and they had all of these weird, neat little different sorts of, things you would sell to tourists, but interesting stuff. And I start to walk towards the back, for any of you who've ever been in there. And there's this big glass case in there. And I keep going, and I'm like, what is that? And in this glass case is a mummy. And the mummy is a Native American that was possibly the oldest Native American that they had found encased in ice. And it was put in a glass case in a place called the House of Curiosities. And I instantly started to cry. And I had to leave. And I really thought about that. Why was it so painful to see a person that I had never personally met? Is because I believed as a Native person that his soul was stuck here and he was not buried with his people. He was made into a joke and placed in an establishment and not put to rest. And so for me to feel, that was a really deep-seated pain. Now, he may have not been from my tribe, but he has a tribe and he has a family, and he's not there. So when you talk about that thing going across generations and hearing the stories, like I told you earlier, that my father told me, that my grandmother told me, those sorts of things follow us because we're a narrative people. We share our history through our language, and so these things get passed down to us. And I don't need to be preaching to the choir. I'm sure all of you have had experience working with trauma. And what is trauma and what does it look like really does vary person to person, but the perspective I'll be giving you is the one from our perspective. Outside the normal human experience, I think you can get from what I've been talking with you today that a lot of what I'm talking about is not within a lot of people's normal experience. But it's been within our community for so long that sometimes it seems normal, so oftentimes people won't, when they describe things to you in a therapy, will say them very matter-of-factly, and you as a practitioner might be going, oh my gosh, if that were me, I would not be doing very well. And they're just telling it to you like it's a normal everyday experience. That is sometimes a very normal everyday experience for most of the people you'll be working with. And these are just some examples. Some of the one-time traumas, of course, that we hear about in the news and personally as well. Natural disasters, earthquakes, floods. I was actually in Grand Forks, North Dakota when that big flood happened in the 90s. Rape, assault, muggings, robbery, and accidents and fires. And Native Americans have the highest rates of being victims of crimes, muggings and assaults and rapes than any other ethnic group here in the Twin Cities area. We also have a very high vehicular homicide rate. So that's something to think about. So these examples of trauma happen quite frequently for us. So what are the effects of prolonged trauma? Well, of course, we've talked about the physical and the sexual abuse. If you look at some of the rates, and definitely the mortality rates, especially for those natives who live on Pine Ridge and around Standing Rock, that area that we've been talking about a lot in the media, the median age range for Native men on the Pine Ridge Reservation is 45 years old. That is the mortality rate for people in Somalia and Afghanistan. You don't need to leave the United States to see war. You would also think that people who are in gangs have some of the highest incidences of this as well. So even though you might not physically be in a war-like situation, you can be in war. And of course, you guys have been talking about the refugee immigrant population this morning, so you have a lot of that information. I'm gonna kind of skip this stuff. You guys kind of know about that if you're okay. But one of the things I will stop on is the issue around hyperarousal. So the biggest thing that we have right now, at least for us as therapists in our organization, is our services within the school systems. Our Native children, especially in the state of Minnesota, are not graduating from high school. If you look at the national average right now, they try to state that people are graduating at a high rate, right? They're saying the state of Minnesota is graduating people around 71, 75%, but that's just your mainstream. If you look at your people of color and actually break out that statistic, it's definitely high. We only graduate less than 60% of our Native kids graduate from high school here in the state of Minnesota. African American population is not that far behind us either. So when you're looking at some of these statistics, what we notice in schools, what do teachers always want to talk with us? The kids have ADHD. Kids, they want them to behave, right? So all of these signs, and almost every time I see them in the school systems, it's symptoms of hyperarousal due to impacts of complex trauma, almost always within the homes. So they're not sleeping, they're not concentrating, they're super vigilant, they're overreacting to people's responses, so they're getting into fights. Starting fights, they're really wary, and they have a lot of anxiety. A lot of my therapists spend most of their time trying just to teach self-regulation skills so kids can maintain and learn within the school systems. And so we're hoping, moving forward, that we can develop more systems that are more responsive to kids who have higher needs like this, because I understand, teachers have high numbers of children in their classrooms. It's really, really hard to teach when you have children who have experienced trauma in your classroom. I'm going to give you some examples. For me, examples always help about why are we still struggling after we had the entry of Columbus in 1492, right? And we're still struggling with a lot of the issues you see. And one of the things that I always hear is, why is this still a problem? I have lots of reasons and answers I can give you for that one, but I'm going to give you an example of a way in which a community did heal. And the story I use is from Canada, but this story can be put anywhere here in the United States. There is the Alkali Lake Indian Band out of Williams Lake, British Columbia. How many of you have heard about them? Good, I like it. Do you know what they used to call this band? The Alcohol Lake Band of Indians. That was the name. They had a 93 to 95% alcoholism rate on that reservation at that time. So I'm going to give you kind of a timeline about how this happened and how they were able to help work on this so you can get an idea of what we need to do. So the documentary that they talk about their story is The Honor of All. They have a website. There's another documentary that they've also added because even though this happened back then, they are still doing really well. As you can see, we had the entry of the Euro-Canadian miners and settlers in the 1850s. Disease from smallpox and other things that were introduced into the native population, of course, decimated populations from, and of course, these are estimates because we didn't have anything written down, from about 14 million natives to about 250,000 natives before even being put onto reservations. So the population was decimated by more than 2/3. By the 1860s, similar to the United States government, the Canadian government didn't want to share anymore, so they started seizing native land. And then they started the forceful removal for 3 generations in 1891 of their children, very similar to here in the United States. And they outlawed language and they destroyed Indian culture. They took away religious traditions and reparative institutions. So, we've talked about this. By the 1960s, the tribe's social and cultural fabric had completely unraveled. So what did they do? The big social activity on the reservation was to drink. They had high rates of unemployment, child abuse and neglect, suicide, domestic violence, all the normal ones that you would hear about, and that 93% rate of alcoholism. So what ended up happening is by the mid-1980s, sobriety rates were the norm and were projected to be around 95%, and those remain consistent today. So how did they do that? That's a pretty amazing feat. And it's exactly what we're talking about what we need to do today. The story is, in the summer of 1971, Andy and Phyllis Chelsea were preparing for their normal weekend routine. So the normal weekend routine is that people would give their kids to their grandparents and they would go off and drink for the weekend, come back on Sunday or Monday and pick up their kids. That was the way that people socialized at that point in time. When they left and they returned, their 11-year-old daughter said, "I am not coming home until you stop drinking." Mother took that to heart and completely stopped that day. Her husband followed 1 week later. What they decided to do is that what they discovered is after they became sober, they didn't have any friends anymore or places to hang out. They literally would have to leave the reservation and go to other places to hang out to be able to do that. So what they did is her husband, Andy, decided he was going to run for the tribal chair, and he ran on an anti-alcohol platform. That is amazing. He had a lot of people fighting him within his tribe and outside the tribe. Because one of the things that the neighboring ranchers did, and this happens in lots of places, is the neighboring ranchers would get the Native Americans drunk and then have them sell their ranching or haying rights and pay them in alcohol. Well, you know when people are drinking, they don't make good choices or decisions. And so he actually won on an anti-alcohol platform. One of the first things he did was he prohibited that practice. He prohibited neighboring ranchers from trading alcohol for hang rights. He trained counselors to run AA groups. Now they're kind of changing it to recovery peer specialists. He ran out all the bootleggers on the reservation. He introduced language classes and traditional practices, and he brought back the language. And he continued to win. So basically, he took away alcohol, and he changed a whole culture. It's a pretty amazing feat to do in a community that socializes completely around one way of dealing with trauma. So I like to tell that story because I think that it's really important in regards to the parts of language and culture, and you can't bring back culture and language if you're currently using. We have a belief that if you are drinking and are using a drug that your spirit tries to protect you, so your spirit leaves your body. And it hangs around, it doesn't go very far. It's tethered to you, but it doesn't stay within you as it's protecting you, because alcohol, when you think about alcohol, there's a reason they call it a spirit, right? Alcohol has a spirit, and while that spirit's in residence, alcohol doesn't sit around. It takes about 4 days for it to come back. And that's a kind of different concept. I had that one time. I was in an elevator with my grandma, and Indians ask who they are by asking, "Who are your parents?" And this young man got onto the elevator, and he had tattoos everywhere, and he was obviously intoxicated, or he was on something anyway. And she asked, "My son, who is your mom, who is your father?" And he said, "Why the F do you care?" And I got instantly angry, of course. And I was going to say something. She said, "No, my girl, no, my girl." And I waited till we got out of the elevator. I said, "Why wouldn't you let me say something?" And she said, "Because you're not talking to that man. That's not him. That's somebody else." And that was a really important thing for me to learn, and it also helps me in my practice about not being frustrated and upset when I have clients who continue to do that, because they're being taken over by something that is not themselves. It was important for me to learn that, and it really helped that perspective, but she really truly believed that that wasn't the man that I was talking to, and it was important not to talk to that spirit. So one of the reasons and why it's been so difficult for us to heal is to give you an example of different kinds of trauma. And I only use one of these examples because it helps you to show why it was so destructive in our American Indian population in comparison to other groups that have also had significant amounts of trauma within their lives. When you think about a one-day tsunami, it's very, very destructive and very traumatic. And then you start to rebuild. But when you have something that's systematic, such as the Holocaust, it's much more prolonged and much more invasive and much more destructive. So collective traumas can be short-lived, such as a tsunami, but they can have lasting consequences or extend over centuries, as they did with us. And one of the reasons why we have such difficulty repairing that, for me, is the second point. We attack the sociocultural fabric of American Indian communities. We took away their reparative institutions to heal, their ability, their spirituality, the outlawing of traditions and ceremonies and language. those are the fundamental institutions. If you think about it, it's your immune system. So how are you supposed to heal if you get hit with a disease and you take away your immune system? You can't heal. So I would say with the thing with our people, the difference is that it's been it's been a really long battle. We've been involved in the trauma since day one, and to be quite honest, the people that have perpetrated the trauma are our government. So we're still living with the perpetrator, if you think about it that way. And that is a real difficult thing to heal with, especially when you think about the provision of services from Western modalities, and even applying for grants and receiving grants to provide services are always really structured without a lot of input from communities of color about how to implement those services. We call these in our community, the words that we use for mental health and mental illness are soul wounds. So these soul wounds are both very deep, and they're both widely shared in the American Indian community. And that, I really truly believe, is one of the fundamental reasons why we're struggling to develop economically, socially, and politically. Oftentimes we talk about building up the sovereignty of Indian people, but we also need to build up the sovereignty of community as well, and people being able to believe that they have the ability to take care of their communities. So when you subjugate Indian people, you treat them as children, you take away their ability to take care of themselves, their confidence and their worldview, and you take away their meaning system, you make it difficult to come back from physical conquest, to not feel like you're a person who has been conquered. So we have to build that up. And to deal with that, we need to begin to heal. We need to heal on a collective level, on a community level, and an individual level. And like I said, I've used the reason of the Holocaust as an example is not to compare traumas, but to give you an example about the difference between the two communities. When Native people were traumatized by colonization, that was 100% of the population impacted by that. Now, this doesn't mean all of the Holocaust people. I'm talking about the people who came to the United States after that Holocaust. One of the things that was different was people from the Holocaust were able to keep their rabbis, they were able to keep their language, they were able to keep their synagogues. Now, I'm not saying that they definitely aren't treated with the negative stigmas, they definitely are, but they were allowed to keep those reparative healing institutions and keep those sorts of things that allowed them to heal with each other. That wasn't the case with Native people. We were not allowed to do that. So we're having to relearn all of those things in some respects, but it shows you why there is some differences in the different communities. We talked about the traditional child-rearing practices. We talked about the boarding schools. We talked about the spiritual practices. And we talked about the other part. So what they wanted to do is they wanted to take away that and then bring in Catholicism. If you go on many of our reservations, a lot of our reservations are Catholic-based. Did you know that? There's a lot of Catholics in the Indian community, and there's some that completely don't practice that way. You'll find more people that don't practice that way actually here in urban areas than you will in reservations. So there are still a lot of people who practice that, and that's a very different institution because we believe traditionally that there is spirit and creator in everything. Animals, trees, rocks, people. Now, when you think about spirit in everything, how you treat that determines how you treat other people. That means there's multiple, not a multiple God, but there means that there's God in everything, for lack of a better word. But the structure of Roman Catholic is one God, and it's based on sin and punishment, so you introduce shame. So they replaced it with this form. So there's a lot of people who are now trying to intermix and interweave cultural traditions. I don't know if you know this, but there is a Native American church in Minneapolis that has smudging and has traditional beliefs interwoven with Catholic beliefs as well. So there are people that are kind of changing and molding that as we go along. But there are things like that that are kind of starting to become more reparative. I like this slide. That's the only reason it's in there. And I don't know how to change the background because I'm really not IT savvy, and every time I do the presentation, I say, next time I'll change it, and I just don't, so that's why it's a different color. But when you think about, when you come into when a dominant power comes into any community, this is not, it's not it's not just Native people. This happens when any dominant power comes in. The first thing you attack is physical and psychological violence. You segregate and displace them, you destroy them economically, and you take away their culture, right? If you do that to the first or primary generation, which was our great-grandfathers and grandmothers, guess what we have introduced? Our physical responses are your nutritional stress response. It's no surprise that Native people have one of the highest rates of diabetes. My grandma used to explain this to me. My grandma had 8 kids, like I've said before. Poor. Have you guys ever heard of commodities? If you've ever seen commodities, so if you get food, like for instance, it'll have corn, it's in black and white, and it'll have it'll black and white picture of a piece of corn on it. If it's beef, it'll have a picture of a cow on it, you know, those sorts of things. But when you get those cans of commodities and you open them up, there'll be a layer of fat that thick on there. Okay, so when you're poor and you have 8 kids to feed, what do? You cook big fat casseroles full of fat and calories so that people can stay full longer. That's just poverty, right? You try to make things that are going to keep people fuller longer with the least amount of bang to your buck. And so we went from primarily being vegetable eating with very little meat to being very meat-based with casseroles. And then when I would work on the school systems in North Dakota, I said, why are you feeding these kids so much fat, you know? What's going on? And they told me this is the one meal that these kids will get all day. So they knew that they weren't going to get fed when they went home, so they would feed them really high calorie food. And then when you think about that, that happens quite a bit to some of these kids. So some of these kids are not eating. And so in the urban area, we call it convenience store shopping. How many of your clients just walk down to the local convenience store because they don't have transportation or don't want to get on the bus with 6 kids or they convenience store shop, so the stuff that's in the convenience store is not really healthy, so the diabetes continues in the community. We also have one of the highest suicide rates, of course. Family violence, substance abuse, and the breakdown of the family. And the psychological response is PTSD, depression, and withdrawal. And then it just goes on and on and on and on. You can do that in 1 generation. It's amazing how quickly you can destroy something in a couple of generations. The positive around that, though, is just as quickly as you can destroy it, that means you can rebuild it back up, too. There is a lot of resiliency, and I will get to that, so don't worry. We're going to get to the reparative institutions soon. A lot of you know how the impact of trauma on the brain works. When you have people who are highly traumatized, the CEO of the brain starts to get overloaded and goes into fight or flight all the time. And that's the part that's supposed to make our reasoning and judgment, right? And so when that is not working, people end up reacting impulsively. And I would say that most of the time when I get people who are in trouble and having to come to therapy because they're in trouble is because of something related to an impulsive act, short-sighted without thinking it through. So a lot of our clients that we're working with are definitely in this fight or flight. They're in survival mode. They're not in thriving mode. Okay. And how many of you have already seen the ACEs study? A lot of it. So if you get a Native child, that score is going to be very high. All right. I have more than 3/4 of our people on our caseload have one of their parents incarcerated. We call the prison system the new reservation for Indians, or the new reservation. So there are a lot of people incarcerated, and that is just really disturbing to me. You'll see that being a higher issue than some of they traditionally don't come into traditional mental health therapy services, as we all know. And we know a lot of those things earlier. So I've already talked about the high mortality rates, a lot of those things, so I'm not going to waste any time on that. I've checked these rates, and they haven't changed. The 37% of American Indians reported that they have experienced domestic violence in their life. That is the highest rate in the state of Minnesota. So we have a lot of our families that are definitely impacted by violence within the home. A lot of the children in our homes that we deal with have witnessed domestic violence within their families. one of the things to explain that a lot of people don't know and get frustrated with, if you are on a reservation, and we're having a lot of problems with this on the reservation in particular, not so much the urban area, but if you are on a native reservation and you are non-native and you abuse a native woman on your reservation, you cannot prosecute them. And we've been fighting that law for quite a while, and the reasoning that we receive from the government is that a person who is non-native cannot get a fair trial on a reservation. I know, right? I will tell you one thing, that's a bunch of baloney. The reason why that's a bunch of baloney is because we understand that if we made a choice and decision about pressing charges against somebody and bringing them to court, that if it wasn't done properly, that would be voided. So we would take that very, very seriously. So what ends up happening is the federal government has to choose to prosecute them, and they don't. And so there are a lot of people who are predators who spend a lot of time on reservations. So that's one of the reasons why that stat is so high. And I'm sure it's underreported. As we all know, most people don't report the violence within the homes. Whites born in the Twin Cities can expect to live to age 81, which is slightly more than the overall age of 80.6 years. I'm going to make it to 90. I'm going to break that stat. And 1.1 years longer than people of color. So the difference varies significantly. Here in Twin Cities, it's an average of 61.5 years. That's really low. So we're doing something different. And this is through the Blue Cross Blue Shield Foundation of Minnesota. I believe that study is coming out again. So I'm curious to see if that stat has changed at all. So I'm going to talk about the things as a Native now in contemporary society in particular that you guys will call microaggressions and things that continue to be traumatizing. The one for me is this issue around sports mascots. When I was going to UND right before I left, that's when the whole controversy around the Fighting Sioux logo came out, and of course we've got our, the one going in the National League. And what happened at that, I was working on my dissertation at the time, and my colleague was working on hers, and to be interestingly enough, she was working on the social, how people perceive Indian women versus Caucasian women in society in general, right when this broke out. And what happened was every year they have the Potato Bowl float. If you don't know nothing about North Dakota, we're all about the potato. So we have this whole float around the Potato Bowl, right? And it's a big deal. And we all get ready on our floats. And every time we do this float, we get really excited because we get to put on our regalia, we get to dance. So we get ready and we bring our children and we dance throughout the whole powwow, or throughout the whole float. And they were preparing for this. And this was at 9 o'clock in the morning. And at 9 o'clock in the morning, 2 frats and a sorority decided to be inebriated, surrounded this float, and were swearing at them and yelling at them, telling them to go back to the reservation. They were nothing but a bunch of drunk Indians, which I find ironic, considering they were inebriated. And when people tried to get off the float with their children, they threw them back on, and nobody helped them. Not one of the other people on any of the other floats helped them, and they did that for half an hour. So they demanded an apology from the university. That's all they wanted, and they refused to give it. So that's when the legal action started about the use of the name. If you can't, and they were doing the tomahawk chop. And I don't, as a Native person, when people do those things and they try to tell you they're honoring you and they're drunk at a game, that is not honoring our traditions at all. But the most detrimental piece of sports mascots is the issue around identity and how people view Indians. When you're used as a mascot, you're subhuman. You're not even a human. And how do you teach your children to be proud of who they are if that's what it is to be Native? My goal is to have every child feel proud of who they are. And you can't do that when you have people mimicking you and using you as a sports mascot. And that's why that's so very important, especially with your young women. All of our children are suffering. Our men are suffering too. They don't know how to be in this world. And when you do that, you make it 10 times more difficult to support a positive cultural identity. Dakota Access Pipeline. Now you can kind of understand what we've talked about, why that's such a huge issue. We are fighting for our traditional sovereign rights, but we're also fighting for everyone. And it's interesting, if you compare the response to the Dakota Access Pipeline by the state, and then you take the one that occurred in Washington, with those guys who went and occupied the federal land? They let those guys stay there for, what, 40 days? Over 40 days, they didn't want to cause, they didn't want to pull guns on them, and they wanted it to be peacefully taken care of. They let them occupy those lands for 40 days. It didn't end in any, other than the guy who got shot at the end and ended up dying. What was the response at Dakota Access? It was very militarized and very, very violent. And I don't know if you know this, but it's extremely dangerous to be Native in North Dakota right now. So the response is completely different. And that is because of that relationship and the viewing of Native people. So right now, this is a huge trigger because it's important for us to stand up for what we believe in. And I think that they did a very peaceful intervention, and I'm happy to see the community starting to do that and try to pray in a really peaceful way. Before people could even go to Dakota Access Pipeline, you actually had to go through training on how to be there. You couldn't be in that camp if you had guns or alcohol, and you had to be there for the right reasons, because of course a lot of people came and attached themselves to it. So it was a pretty big deal. We actually have some kids who have been there. They actually had a school there. And we actually have some of our kids back in the schools here in the Twin Cities now who've returned from there. So it's been a really interesting experience. Another of the traumas is the opening of private or state-run casinos. And for me, this has always been, I'm gonna go down. The reason why it's such a big issue is related to the current myths. I don't know why this is, but I continually run into the issue of people thinking Native people are really, really rich and seem to be really upset about that. And it's directly related to the issue around casinos. I don't know if you know this, but most Native American reservations and tribes in particular are very poverty-stricken. And casinos have not been the answer. You have about 9 casinos that make any significant chunk of money in the United States total, 3 of them in the state of Minnesota. And for some reason, there is this mentality out there that we have a lot of money. It is just not the case. For my tribe, we have more than 13,000 members. Our money goes back into our community. But when you make a significant chunk of money, each tribe gets to define what they do with that money. For instance, the Mindewakan community puts more than $4.6 million into the Minnesota Twin Cities area. They actually fund our community holiday party. They fund coats for our kids. They do lots of different things for people that I don't think a lot of people know about. That's a lot of money to put back into a place, and it's kind of one of those unheard things. The other thing that really is really difficult to stomach, especially in this day and age, is immigration law discussions. I'm just gonna give you a shout out. You're all immigrants. Having these conversations for Native people are very, very triggering, because we're all here, we can find a way, we are all related. We need to find a way to live together. And every time we hear these discussions, it re-traumatizes us because it makes us very angry. And what you'll hear, and that's why we have to walk out sometimes, because we can't have the conversation because the hypocrisy is just so blatant that it's hard to stomach. And it's hard to turn that stuff inward. It's really hard. Right now you're getting white Jessica right now. You're not getting native Jessica right now. There are different identities, and you know when you can be who you can be in the area that you are. I mean, I think that probably makes sense to some people. You have to control who you are if you want people to hear you. Columbus Day, you have no idea how reparative that was when the state of Minnesota did that for us, and they added Indigenous Day. We do not close at the Family Center for Columbus Day. Columbus, for us, is a rapist. He is a perpetrator. He is not a positive image, and we don't want our children to embrace that and to embrace that history. I have actually been in arguments in high school. On my tribal school, I had to have a history book that depicted things that were not true about my people, and they made me study it. Jessica, just put down the right answer. Really? No. The EPPP, you guys. There was a question on there about Native people. I got it wrong. I was lividly angry. I said, if this is the right answer, and you're telling people who are taking this test that this is the right answer, you're going to have people actually failing if they go to a reservation. You know what? They took it off. I'm sure it wasn't just me. I'm sure a lot of people wrote in about the question. But it was really, it was kind of, traumatizing to get the question wrong. I literally yelled around my house for 2 hours. How in the heck did I get that wrong? That doesn't make any sense. Halloween. I can't walk into places like Party City or any of those places that show me one more sexualized version of Pocahontas again. I don't know about you. I grew up Native. I'm not able to talk to squirrels and raccoons and whatever the heck Pocahontas is singing to. We are depicted as these very spiritual beings that somehow communicate with animals. And while I enjoy the belief that we're these spiritual creatures, everybody's a spiritual creature, it is not an accurate portrayal of who we are. And those media messages really impact our young women. I don't look anything like that lady that Disney has created at all. And I've never seen a Native woman wear buckskin off her shoulder with one arm out either. I'm like, where did that outfit come from? So I don't do that. And I also realized, though, when I was doing that and I was getting mad about that, I also realized I was appropriating culture, too. I got really mad at myself. I realized, hey, you're getting mad about this. Guess what I had in my closet? I had a geisha outfit in my closet for Halloween. And I'm like, okay, you can't be a hypocrite here. So I took that out and I threw that out because I had no business wearing that. But it's just, I know that sounds like a little thing, but it's a huge thing for people to have their culture taken and then used. We've talked a lot about that. There are a lot out there. I'm just going to give this as an example before we can get to the resiliency for you guys, because that's the cool stuff, the fun stuff. These are some of the poorest counties. Now, I don't know what the heck is going on in South Dakota and Texas, but as you can see, the poverty guidelines are pretty significant in those counties. If you take this down and overlay it, if you were to take the map of the poorest counties in the United States and overlay it on that map, which I've done, a reservation lies in every one of them. Your poorest county is Beltrami County here in Minnesota. That's where Red Lake resides. So we all know what happens with poverty. So the good stuff, culture, strengths, and resiliency, right? The things that we want to get to. Even with all of that stuff that I've shared with you, there are some unbelievably powerful and resilient people out there. We are still around, so that's saying something. So what are the resiliency factors that are within the community that we can utilize and that are there and that are vibrant? Have you guys heard the phrase Mitakuye-osun? Okay. Native communities believe that we are all related. All people of colors. If you were to look on the internet right now, you'll find about 1 trillion medicine wheels. That's because there are a lot of medicine wheels out there that mean lots of different things. If you think about it, the medicine wheel has what? White, black, yellow, and red. All the different directions. One of the Hopi medicine wheels that is out there talks about the different people that are in this world that are necessary. Of course, the white is your white people and the strengths that they bring. The yellow is your yellow people and the strengths that they bring. The red is your red people, of course, your Native people, and your black is your black people. And they're all integral and need to be in balance to be able to function well. So that's where that term comes from. We are all related and we all have a place and we all have strengths, we all have values to add to this world. We have experience with trauma. If you know something, you can recognize it. You can heal from it. You can then teach other people how to heal from that, right? One of the things that people don't know is there's a lot of research that's geared toward chemical dependency, especially with Native Americans. So the image out there is that there are more Native Americans with chemical dependency problems than other groups of color. What you need to know is that actually that's not exactly true. If you compare it per capita to the amount of Indians out there and the amounts of rates and differences, it's pretty much about the same. But what you'll notice, and which is not talked about, is the highest rate of abstinence. They have the highest rate of abstinences from substances after they do obtain sobriety. So the recidivism rates are actually lower, or they do better. So, and the ones that I've seen do better are those ones who have used the traditional values and cultural pieces. One of the ways that we look at people that I think that the field kind of struggles with sometimes is a real holistic view of life and healing. We look at one small aspect of a human being, and we need to be looking on a much larger aspect. All of the treatment plans that we do with the people that we serve are within the medicine wheel format. If a person, for instance, if a person, even if it's not about issues related to spirituality and culture, we spend a lot of time talking about that. That's part of our treatment plan. Any of the physical aspects are part of our treatment plan. Working out, exercise, health. The mental health symptoms, of course, are a part of our treatment plan. And mentorship is always built into those sort of programs as well. One of the other things that we have a lot of respect for, and I've talked a lot about, is our elder respect. We do a lot of work with our elders in our communities, and we utilize them within our healing practices at the Family Center. We have medicine men and medicine women that we utilize, and they do lots of ceremonies as an adjunct and a tie-on and work collaboratively with the therapists to ensure that they receive those services should they want them. There might be some Native people who don't want any of that and do a little bit better in different modalities, but that's really individualistic. So we do have people that come in and that do those sorts of things for me. The one that I always use is I had a young woman, single mom. She was struggling, and she knew she was struggling, and it was really interesting because she was giving her child a bath, and he threw water in her face, and she spanked him. And what she did is she immediately called for help, because she didn't want to do that. And so we were working together, and she had a lot of grief and loss, and what she decided to do was to do a grief and loss ceremony. So I didn't have that experience in that particular tribe she was from, so we brought in a traditional healer, and he did a wiping of the tears ceremony. She literally was done with therapy in 2 months. For her, that was the thing that worked. And she called me. It was, you know how you guys get so excited to get those ones where you get, you did a really good job, and they're just doing well, and you're so excited, and they give you courage to keep seeing clients, and like, am I making a difference? She called me 2 years later, and she had a job, and she was helping other mothers just like her, and she was so happy, and she called to thank me. And it was just unbelievable to be able to have somebody call you back after 2 years and just share that with you. And that was not because of me, it was because of her willingness to do the work, but also the ceremony. So when we look at illness, this is the interesting thing as I've talked about evolving as a therapist. Being brought up in graduate school and expectations of learning modalities and theories and how to implement them, I found to be very rigid. We have developed a system, interestingly enough, to heal people based on a model of sickness. To me, that logically doesn't make a lot of sense. How can you get better in a model that is based on a sickness model? Now, I understand that we need to identify, we need to diagnose, and we need to explain to people what that means. But we also need to spend a lot more time ensuring that they understand that that's not who they are. We use it to guide treatment, but we shouldn't use it to penalize and label. We need to look more at wellness and health and the positives and resiliencies in people and pull those out rather than focusing on all the behavioral issues. I know that those are important, but sometimes I think it's short-sighted to just focus completely on there and say, okay, now that you're not doing this and you're not doing this, that's a success. You see what I'm saying? The issue is to help people not get into trouble, right? I mean, that's really what we're doing. For Native people, our view of looking at mental health and illness, we really didn't have a word for illness other than soul sickness and being out of balance, kind of like the wheel. That's why you'll always see wheels with us. We're always in circular motion. And if any of those little ridges in the wheel are not in place, then guess what? You're bumpy, you're falling over, things start to fall apart. So our descriptions of how we feel are really fluid, and they change. They're very descriptive. You'll have people saying, I have a heart sickness, I have soul sickness. I don't feel tethered to the ground. Indians need to feel really connected to the ground. So these are some of the descriptions you might hear, and how do you diagnose something like that? So we think about things holistically, and that's where we need to go. We need to be in balance with these clients. This is the one that we use right now, at least in our therapy practice. And as you can see, there's tie-ins of balance and respect, and I'll give you some examples of how we do that culturally. When people engage in genuine healing, they become more accountable. Now, this is my statement, and in touch with reality. Healing generates compassion and tenderness. And to heal collective trauma, you must heal the individual, and healthy individuals give birth to healthy institutions and healthy cultures. It's circular. So we need to intervene, and we need to intervene on a macro and micro level. And we're doing some of that work already, and I'll give you some examples that you can take with you. In the community, we need to bring back values, we need to bring back customs, traditions, and language. There are a lot of language camps in the summer, so if you're ever looking for language summer camps for Native youth, they're all over the place, and they're competing all the time. And those are really good ways in which to get people into their culture, because much of culture and traditions is translated through language. There's just some things that don't translate and make sense in English. And so that's why it's so important to bring back the language. We are conducting healing ceremonies. One of the things we're working towards is, and it's still a colonized approach, but it's still helpful, is actually finding ways to get things like naming ceremonies and healing ceremonies actually reimbursable, seen as a valued service and an adjunct to therapy to help people. There is a organization out of Detroit that is actually doing that. It has received SAMHSA dollars, the Art of Healing. If you were to Google the Art of Healing, the Anishinaabe Healing Circle will pop up. And they have a lot of good ways of showing you how they have done that. And so everything's brass coated. Even sweat lodges are brass coated out. So just like you would in a hospital setting, you would fill out your little form and say, okay, I'm going to do this and this with this client. I'm going to do a naming ceremony, then I'm going to do a sweat ceremony, and then I'm going to do EMDR, right? Because that's all on there too. And you're able to fill out your little invoice form, do that, submit that, and get paid. So what we were doing a lot is, a lot of our stuff that we do as healing is we also have people participating a lot in community activities. A lot of our clients are socially isolated and unwilling to kind of go out there or don't know how to develop that. So we have that written in as well. And the thing that I talked about today, it's really important for me to be here today. If I want to see change and I want to see people do good work, I need to educate. And so that's the important thing, is making sure people are getting out there and providing that information to people. One of the things that we do through our community, and the biggest thing that you'll see Native people talk about, any research that you do find out there about Native youth and how to help them, all involve mentorship. All the people that did well or started to improve had either a teacher or a family member or somebody in their community that they were able to look up to and positively connect to. And those were the kids that did well. So mentorship programs are extremely important. We have people calling all the time to connect their clients to us. And we pair them with somebody if we have the capacity. We only have 12 employees, so that can be kind of difficult. Sundance ceremonies. We do everything in talking circles. Almost all of our groups are in that format. It's really helpful, especially when you're trying to control over-talkers in groups. I'm sure you guys have got some people in groups that you'd like to find a nice way to kind of bring back and allow other people to talk. But when you do talking circles, that allows you to be able to control that a little bit better. How many of you have done talking circles or been a part of those? Yeah, they're helpful to manage some of those behaviors, and Native people respond well to those. I didn't bring any of my medicines today, but all of the therapists have things in their office that are around smudging and the traditional sacred medicines. We often use cedar tea, and we use cedar tea in therapy for healing and purification. And you can give those to clients either in cold or hot format. I have recipes for that, so I can always send those out later on if you guys should want those and use those. Those are wonderful things to use with clients. And you can use smudging. That is not something that's specific to Native people. You can use that and have that available. When Native people see those things in your office, they get more comfortable. And sometimes you can just ask, do you want to smudge? And if they do, you can. We open up that way and we end that way. We also have people who come in, we give them those things, so we keep those supplies on hand. A lot of our elders, you'll find them, I took a ride with one of my elders. We were going up to Grand Portage. She goes, oh, stop right here. And she found some red willow. And we had to get off in the ditch and go foraging for this red willow because she saw it from the road. And red willow is traditional tobacco. So if you want to make traditional, kinnikinnick. So if you ever heard the word kinnikinnick, traditional tobacco doesn't have any toxins in. So red willow is really hard to get. You need to get it before the snow hits and before the DNR starts cutting it down. And so there's a real window of opportunity. If you see red willow, grab it, and all you need to do is get like a potato peeler, take the red off, and then the shavings from that are traditional tobacco. So if you want to ask an elder for knowledge and or to do something for you, you need to make an offering of tobacco. And they prefer traditional tobacco because things that you can buy, cigarettes have toxins in them and have other things in them. You can, in a pinch, just give them some regular tobacco you got from a tobacco shop, but, you know, and they'll accept it. And here's a little tip, but don't tell the elders I told you. If you offer an elder tobacco to share their knowledge and or do something for you, they have to accept. So treat that power with well. One of the beautiful reparative things that are going on, if you don't know about this happens in October. This happens at the Minneapolis Center. This is the gathering for our children and returning adoptees powwow. Have any of you heard about this? There are a lot of people that have been taken out of their tribes that are returning back to the community. A lot of people that have been adopted out, and they come to this powwow because they're returning back to the community, and so the community welcomes them back in. And that happens around October 10th. I believe. I have to look online to see when it is this year. And it's a beautiful thing for those people who've been adopted out who come back in. So that's something that you can send them to, and they'll be well received. Individually, we heal, like I said, through values, customs, and traditions, and we increase our positive concept. And the biggest thing is the positive and supportive relationships. Just because people are coming from some families that have a lot of trauma, they may not have people in their lives that are necessarily supportive. So how do you create support in that atmosphere? And that's why it's so important to have them involved in these community events, because there's always somebody there that are willing to listen to their story and take them on. We adopt family members. So oftentimes when you hear Native people talking, they might say my auntie and my uncle. That doesn't necessarily mean that's a blood auntie or uncle, but it's still their auntie and uncle. Just like if you adopted a child, right? That's your child. It's the same way in that concept. So these relationships are inevitably very important. Mentorship is also really important, like I've talked about. One of the ways in which we can be involved in community is to give meaning back. So when we start to heal, a lot of the Native people that we mentor, we say, okay, which ways can you give back now? And that's really, really important. And some of the ways that they have done that is by mentoring another parent or another person and kind of keeping the cycle going. Some of the examples I've talked about are the naming ceremonies. There are atonement ceremonies. A lot of the schools are really big on this traditional restorative justice practices. I don't know if you know that, but that's based on traditional models of restorative practices. We've been working on that for over 10 years in Ramsey County, trying to get the schools to do that. And it's actually a way in which to repair your relationships after you have done something that has caused harm to somebody else, which is important. And those were already built in. And so atonement ceremonies to make atonement and ask for forgiveness and be brought back into the community. Coming of age ceremonies, we just had one last night. It was full moon last night. I don't know if you guys realize, but it's extremely crazy around this time, isn't it? I bet you your practices are blowing up with tons of issues right now. ERs were probably full. But coming of age ceremonies is really, really helpful because it tells a woman and a man when they become a child and have transitioned to womanhood, or a young man has transitioned to be a man. And so what they do in those ceremonies, for women, it's when they hit their moon, when they hit their menstrual period. And so they're brought into the circle, and the women in the community explain the responsibilities and the privileges of what it means to be a woman, the power that's involved in that, the power that their body holds to create life, but also that about the importance of respecting their body, and that every time you are with somebody, you are sharing a piece of your soul, so that they understand the power and privilege, and they are treated as a woman at that point. But they also have to learn about what it means to be that woman. I can only speak from the woman's perspective. I can't speak from the man's perspective. But that was a really impactful ceremony to go through as a young woman, and it was really important for me. It really helped because then I felt, oh, I'm a woman now, and I had to act like it. So that's the difference. A lot of our young kids don't really know when do they become an adult? And so they push those boundaries all the time. If you have a ceremony that says, hey, you're an adult, but we expect this from you now, you will see changes in behavior and how your kids respond. The use of traditional medicines, we do that all the time. So when you work with people, you need to know some history, you need to learn about the strengths and the resources in the community, You need to integrate culturally responsive services within all your models of practice with whatever community you work with. This is not just specific to Native people. So whatever community you choose to work in, I encourage you to interweave traditional values, teachings, knowledge, and ceremonies within all of that, and to ensure your organizations are trauma-informed. There's a huge push for that right now, for trauma-informed organizations, and it's really hard to do that, but I think it's really important. And social justice and advocacy. I really think we need to start being allies and stand up for things that are outside our communities. So if you see something that is not wrong but isn't directly impacted, your life isn't directly impacted by it, it's important to say something. If we are in the business of healing people and providing support, we need to look outside of ourselves and the groups in which we reside within. And that's why we talk about that, but we also talk about trying to recognize cultural healers as just as important in the process of healing as us. It doesn't help us to...
I don't know what you mean by... We also talked about trying to recognize cultural healers as just as important in the process of healing as us. How about a web search for it?
Siri wants to know. See, even Siri doesn't know. Non-Western treatment modalities. I am so proud of the work that they do. And these people have let me use these pictures. They say, please use them. These kids are awesome. These are the dream catchers. This is our trauma-informed psychoeducation group for children ages 7 to 12 years of age that follows a curriculum that interweaves traditional stories and activities as a way to assist children in developing self-regulation skills to manage trauma response. The children in this group, this is all based off the medicine wheel, so they all follow seasons and the animals and the values. So one of the things we've been doing in the community to repair relationships, as you can imagine, we don't have a great relationship with the police department. Our little children do cookies and they bake and then they bring that over to them. A lot of our children have been traumatized because when the police come in, they're taking them away or they're taking a parent away. And so we wanted them to be able to see them as helpers as well, so that they could get help when they needed help. And because these kids do this, they do this quarterly, by the way. They also go to the fire department and do this. The police department drives by our place a lot more. Yeah, it's amazing. And so when we have to call them, they actually respond within 10 minutes. Yeah, we get a great response, and they just love them. And so this group focuses primarily on identification of triggers and feelings, self-regulation skills. I had a little girl, this was hilarious. She was so sweet. Her mother was activated and she was having an anxiety reaction at home and she was upset, and the little girl was running around and the mom said, I didn't think she was paying attention to me, so I didn't think I had any impact on her. Trying to explain to a parent, your mood impacts your child. And the little girl stopped playing and ran up to her and put her hand on her belly and said, Mom, remember deep belly breaths, Mom, belly breaths. And she was teaching her mom how to deep breathe. She reminded her own mother because she was doing that already in this group. Sugizin Dodem. Sugizin Dodem is an Ojibwe word that means strengthening families. This is our trauma-informed family psychoeducation group that couples traditional and cultural teachings with the creation of art with current mental health knowledge about trauma and trauma response. And you'll be hearing a lot about trauma response from your next speaker. This class focuses on education and feeling. The whole family comes in. They learn how to, I know this might sound crazy, but they learn how to have a meal together. A lot of people who are homeless and are not living together don't necessarily know how to have conversations around the table right now. So a lot of the therapists sit there and model ways in which to talk and communicate. A lot of things get worked out around that first bit and piece of that. They then learn, this woman had never beaded a day in her life. And she beaded a medicine bag. She wanted to share with everybody her biggest thing that she got. She called us up because she found a home after this group, and she was able to get her kitchen table out of storage, and they were able to have a meal together. And she was so happy to just cook a meal and have a kitchen table and to be able to do that. And that was the thing she took from the group. So something as small as a meal together can be healing. And a lot of her relationships with her children got better as a result. Ombiaye, Anishinaabe, and Inawug. Rise Up Original Men, our father's support group this group has received dollars to reduce diabetes in the population. So the way that they've chosen to do that is through their drum group and through their summer activities and their winter activities. So they have a softball and a football team. And it's hilarious because when we go to these events, they have the most family members there. They'll have like 60 or 70 people coming to support them. They don't usually win, but they have a ton of fun. And everybody always comments about how connected and cohesive they are. This has brought families together. This is the Elders Lodge. This is where we were last night. This is the picture from last night, but we were doing this last night. And the men are asked to do drum groups. As you can see, there are little children around there. It's really important to have the children and the women involved in this as well. And they learn how to sing, they learn their language, and they learn how to give back to the community. Because when they do this, these are people calling them in and say, hey, we had a death in the family, or we had this happen. Can you come in and do a drum group for us? And they come in and they do that for them, and they're really supportive. They also have a camp up at Mille Lacs. So a lot of these Native men haven't actually gone camping or any of those things, or know how to even start a fire. So at Mille Lacs, they have wild ricing. They also do their own maple syrup. So we get super excited because then we get our own maple syrup at the family center later on. And they actually have to learn how to do these things. So a lot of the men are learning those things. Our Western modalities, before I let you guys ask them questions, the ones, I'm not a belief in that one thing fits all. I found that little bits and pieces of all of these have been very helpful for us. But EMDR has been really helpful at times. I would say that the thing that I see with EMDR, though, is that the things do come back, and you still do need to do additional sessions to kind of help keep you up to speed. Trauma-focused CBT, somatic experiencing therapy, and narrative and art therapy have been really helpful. Our narrative and art therapy, in particular with our children and our adolescent girls, has been really helpful, especially for people who are nonverbal and need to work on things differently. These are some of the cultural adaptations. If you look online, there are very few cultural adaptations for American Indians. And of course, we all have lots of thoughts and feelings in the Indian community about evidence-based practices and about the implementation of those. Honoring Children Mending the Circle is a cultural adaptation of trauma-focused CBT. All of my therapists are trained in EMDR, TFCBT, and that particular model of treatment right now. I would say that the difficulty with implementation of trauma-focused CBT within Indian populations is really around the parent involvement. It's really difficult to get a lot of our parents involved in that component and piece, so we often end up having to find other family members or people that want to do that piece and component. Honoring Children Making Relatives is the cultural adaptation of parent-child interaction therapy, for those of you who have been trained in that. Honoring Children Respectful Ways is the treatment of children with sexual behavior problems, which is a cultural adaptation. And Honoring Children, Honoring the Future is the American Indian Skills Development Curriculum. All of these have been very good. They're out of Oklahoma. The person for that is Dr. Dolores D. Bigfoot. And she will work with she works with everybody. They have a lot of treatment models, a lot of resources on that website. Honoring Children, Honoring the Future, and the new one that's come out of Canada, Aboriginal Focusing Orientated Therapy. You don't need to be a therapist to do that. That is a 10-week course that uses traditions and values. They are a liaison between the mental health field and mental health practitioners and the layperson. So they do a lot of connecting. So it kind of really helps to reduce that stigma for those people who are unwilling to kind of come in and do the Western modality approaches. I've talked about mentorship. I've talked about conducting activities in small groups and implementing elders and medicine men into the treatment. Those are the common elements about why those adaptations work. Everything really breaks down to self-regulation skills, positive coping strategies, and allowing safe places to talk about their experience. These are some of the things that you can do to create a safe environment. Have an office that is trauma-informed and peaceful. Offer something to drink or eat. We have tons of food. Matter of fact, I just got yelled at because I brought in a ton of food for Mother's Day early, and so we have people eating. We always offer food to people when they're coming in. The therapeutic process takes a lot longer to build trust, so you need to allow that time to do that, and that is difficult to do in an insurance-regulated field, but is necessary. If you want information, a good way to start is to ask about family and who's important to them, because they will be willing to share those connections a lot more. Connect them to their culture and explain your reasoning for why you're suggesting. Now, this last one is a little difficult, but we like to laugh. It's one of the things that's kind of kept us sane. So The use of humor can be appropriate, but of course you have to use it when you've had a better relationship with them. And Indians generally repeat it. This is how you'll know when it's working. If an Indian teases you, you are in. That means they like you. They will tease you mercilessly. It was one of the ways in which we used to keep people in line too, but that means that they like you and that you're accepted. The problem for practitioners is if they don't like you, they just leave, and you don't even know why. They're not gonna be like, they're not gonna get mad at you or yell at you or do any of those things. They're just not gonna come back, which is much more difficult. I've already talked about some of that. And I'll leave you with this so you have time to ask questions. This is really, really important for you practitioners out there. In traditional Native American teaching, it is told that each time you heal someone, you give away a piece of yourself until at some point you will require healing. You are sharing a deep part of your soul and your spirit. You got into this because you wanted to help people. And you can't do that if you're always giving away yourself and not replenishing. So if I can leave you with anything, and the reason I say this is because I know therapists are traditionally horrible at their self-care. It's really important. And I wanted to thank you for listening to me. That's my contact information. We always welcome, we would rather have people ask questions than not ask questions. Please, if you have any questions, please feel free to call, even if it's not here.